डायरेक्ट आ जाएगा ना। हम्म, रूम में। हम्म, ओके। मैम, आई थिंक मैं ओके। ओके। Mm.
A very good morning, one and all, and a warm welcome to all our eminent speakers. Today world is speaking about. You have seen many heart failure cases at our hospitals, and in entire world is speaking. Many cardiac patients are suffering with heart failure disorders. Today we were going to concentrate on heart failure topic, especially what kind of nursing interventions we have to take care of such kind of clients, and what nursing care perspective, like when you're dealing with patients with heart failure, like cardiac symptoms, what kind of care you have to take. Today we have with us with eminent speakers. We are going to deal about this webinar completely on very interesting and enthusiastic topics, which speakers will take us completely went through by heart failure, what you have to do on nursing perspective and nursing care and interventions we have to implement. So without taking much delay, first of all, we should know short note of heart failure, what is heart failure, and what we have to know about heart failure, and in a world how many globally how many cases are, we have mortality and morbidity in a day-to-day lifestyle, how many cases are, we are getting in mortality and morbidity, and how many cardiac arrests are occurring in India throughout the global history. I'll just go through. Heart failure is a pathological condition in which heart unable to pump enough blood to the rest of the body, because it is either unable to fill with a sufficient volume of blood or unable to generate sufficient force to pump out enough blood. It is not a condition in which the heart has stopped pumping. So many of you seen, what is heart failure and how many cases you have been, when especially post PTCA, you have seen vasovagal hypotension patients may drop into hypothermia changes and hypovolemic shock, and sinus ventricular tachycardia, atrial flutter, atrial fibrillation may leads to heart failure. Many cardiac, rehab centers now, making nurses expertise in cardiac skills, where they have to be put effort to take care of such kind of dysarrhythmias and how patient may lead into heart failure. This kind of perspective. Today we will learn about heart failure. Heart failure is a serious health condition that contributes to 8 deaths in the US and impacts nearly 6.5 millions in Americans, said Norman Stockbridge, MD, PhD, Director of Division Cardiology and Nephrology in the FDA Center of Drug Evaluation and Research. The research was conducted in years. If you take up research, 6.5 million Americans are nearly they are prolonging for heart failures. And this approval provides patients with heart failure with reduced ejection fraction and additional treatment option that can improve survival and reduce the need of hospitalization. All of you know, when doctor suggested for any heart failure, they suggest for us echo, dopamine stress echo, echocardiogram to know ejection fraction. So in that EF, how much failure of EF, and they will lead with the heart failure may occur. So the prevalence of heart failure is escalating rapidly, compounding this, and this illness consumes substantial healthcare resources, inflicts considerable morbidity and mortality, and the natural history of the disease with a broad range of medical therapies. You have seen lot of devices and lot of cardiac intervention procedures. Even our expert cardiologists are doing to prevent this heart failures and many cardiac dysarrhythmias. How to identify with basic investigation, and how it leads and their life style modification, and what kind of health checks are happening. Lot of awareness today's in you take up in the world. We have lot of awareness, lot of people were knowing what diet to be eat, what to eat, what not to eat, and what kind of lifestyle implications to be implement, how much we have to jog every day, how much walk we have to do. Everybody, today's world is era, even today's school children are wake up with basic life support, what they have to do, and what how many steps in a day they have to walk. Everywhere now awareness is so much, and it is part of the healthcare employee. It is our hands to prevent this heart failure. And when you go into deep epidemiology and natural history of heart failure, incidence and prevalence in developed countries, the age adjusted incidence of heart failure may falling, presumably reflecting better management of cardiovascular diseases, but due to aging, due to overall incidences increasing, and current bad food habits and eating inactive daily lifestyles. The instance of heart failure in Europe is about 3 into 1,000 persons in years in all the age groups. About 5 into 1,000 persons in adults, especially adults are affecting with heart failures and with the between age group of 45 to 55 years of age group in Europe countries. The prevalence of heart failures appears to be 12% of adults and likely higher and 70 years of over. Maybe if you take age groups of in India, you have seen now 45 to 55 years most effectively we are prevailing this age group and there are a lot of cardiac interventional procedures are happening to identify what is the cause of heart failure and what kind of dysarrhythmias. So there is a lot of research is going on. For long term, if you wanted to register this outpatient setting, we need to have, as last time our Dr. Nitin said, we have cardiac rehabilitation centers. So many of nurses, enroll with such kind of courses, cardiac rehab therapy, like how you wanted to evolve in your nursing skills and what kind of, mechanism you need to adapt. There are a lot of awareness, a lot of buzz was created in the market. Healthcare media today become, vocal and everybody is aware what to do, what not to do. So there is specialized nurses training in cardiac rehab. We are, pipeline into the project and the cardiac nurses will take up, this kind of challenges and they have to be evolved with this cardiac rehab therapy and they may take up special training on this and this is the motto which we wanted to make academically strong and you make it in bedside also how you wanted to skillfully. With this conclude note, I would like to invite Dr. Damod Reddy sir and Dr. Nitin sir. They are here with us, you know. So today's they will take us, complete what kind of nursing care perspective you need to deal with heart failures. So how you wanted to, take care of such kind of patients with heart failure. So without taking much time, now I would like to invite Dr. Damod Reddy sir. Dr. Damod Reddy sir is finished his MBBS MD DM cardiology and he had 6 years of experience and he was working with us in High Tech City last 3 years. And sir was expertise and his specialization in interventional cardiology and complex coronary and structural interventions. He has scored many academic awards during his long clinical career, and he has special interest in the vastly advancing field of structural cardiac interventions. He has best skills in clinical management of heart failure and various cardiomyopathies like dilated cardiomyopathy, hypertrophic cardiomyopathy, and etc. And sir, well known of Hindi, English, Telugu, and Malayalam. And he has many awards, rewards, and recognition in his career. He was awarded gold medal best outgoing student MBBS batch by AP Medical Council Forum NTR University. He was awarded 5 gold medals for best performance in pharmacology, general surgery, orthopedics, and merit award in OBC and ENT exams conducted by NTR University. He was awarded Best Oration Paper Award in General Medicine Epicon. So, sir was with us, and today he'll take us, what is heart failure and the pathophysiology of heart failure and what he wanted, classification of heart failure. And he would like to take nursing interventions, how you have to deal such kind of patients. Thank you, sir. Over to you, Dr. Damodar.
Thank you so much for kind words. Good morning, everyone. Uh, First of all, I thank Medicover Management and Nursing Department for giving me this opportunity to speak on heart failure classification and evaluation. And I also thank Dr. Nitin sir for organizing such a, good topics of a discussion. So today I'm going to discuss regarding classification and evaluation of heart failure. And these are very basic things which I'm going to discuss and also very important things, especially nursing perspective, because sometimes in the ICUs and emergency medicine, these signs and symptoms and also evaluation becomes very important. And these are very basics which we were teached in our MBBS level. And it's also very important for you also. You might be knowing what is heart failure and you may be having some clinical background. You will just refresh regarding that today. So what is heart failure and definition of heart failure? According to ACC and AHA, it's a complex clinical syndrome that can result from any structural or functional cardiac disorder that impairs the ability of the ventricle to fill with or eject blood. So it can be a problem with filling or it can be problem with ejecting the blood. And it is caused by abnormalities in both systolic and diastolic, or it can be mixed. Okay, and can occur in from any disorder damaging the pericardium, heart valves, myocardium, or ventricular function itself. So you can just remember from outside the heart, or pericardium is which covers the heart, myocardium because of myocardial damage, or endocardium, that means the valves or anything which can, all these factors which structurally contribute to the heart can be the etiology for the heart failure. So this terminal condition of many cardiovascular disorders like myocardial infarction, valvular heart diseases, and various cardiomyopathies. So by definition, heart failure could be the end stage or the end result of a primary etiology of heart. So that could be most commonly ischemic heart disease, very most common, which is the leading cause for heart failure in India, and followed by valvular heart disease and various cardiomyopathies like dilated cardiomyopathies, hypertrophic cardiomyopathies, or infiltrative cardiomyopathies. And you should not forget that hypertension is also one of the leading cause for heart failure. So as I told you, these are various etiological factors which contribute to heart failure. First would come the coronary artery disease, that is with myocardial infarction, and later comes the arrhythmias, that is sometimes patient with chronic atrial fibrillation or may land up with tachycardia induced cardiomyopathy. And with atrial fibrillation there is loss of atrial kick, which is helpful, which contributes to cardiac output, that also comes down leading to heart failure. And arrhythmias can also be the triggering factors when the patient is already in decompensated state. With compensated state, it may lead to decompensation. We see lot of patients with stable heart failures coming to ER and OPs with atrial fibrillation with fast ventricular rate decompensating into heart failure. So this is one of the triggering factor. And valvular and congenital heart disease, like all the valves can lead to heart failure. Most commonly in India, rheumatic heart disease, mitral valve is the most common, followed by aortic valve. And atrial septal defect and ventricular septal defect can also contribute. And alcohol and some of the drugs which are cardiodepressants can also cause myocardial damage and contribute to heart failure. And various cardiomyopathies and like dilated, hypertrophic, and restrictive cardiomyopathies like amyloidosis, sarcoidosis, and hemochromatosis can contribute to heart failure. As I said, the outermost structure of which covers the heart, the pericardium, pathologies of pericardium like constrictive pericardium, pericardial effusion can contribute to the heart failure. And also right heart failure contributed by idiopathic pulmonary hypertension or any secondary functional tricuspid regurgitation, which may lead to right heart failure. And lastly, the high output failure. You can see when the heart, when you ECG is normal, echo is normal, sometimes patient will be already in heart failure. So though structurally heart is normal, patient can develop heart failure in conditions like severe anemia. This is called anemic heart failure. When the patients, especially we see in pregnancies, patients landing up in decompensating heart failure, we see hemoglobin of 2, 3. So in that case, because of high output, it is the leading, it leads to heart failure. And thyrotoxicosis. Thyrotoxicosis causes hypermetabolic state and with high heart rates and more demand for the heart to pump. So that can also contribute to heart failure. And AV fistula also a kind of high output state because of high artery to venous. And we can see a lot of patients with CKD on AV fistulas. So in these kind of patients, they are also prone to high output failures if the fistula, they are large fistulas. And Paget, this is also one of the reasons for high output failure. So coming to the after etiology, we see the incidence, which is the most common factors which cause heart failure in India. So you can see here clearly the first bar contributed by CAD or ischemic heart disease contributes to 64%, followed by hypertension, followed by diabetes, followed by valvular heart disease caused by RHD. Next, peripartum cardiomyopathies, anemia, hyperthyroidism, cor pulmonale. Cor pulmonale is just a right-sided heart failure secondary to lung disease or primary to the what you call any other interstitial lung disease. Next, hypothyroidism can also cause, it may cause pericardial effusions. We see a lot of cases present with severe hypothyroidism with pericardial effusions, myxedema, coma. And connective tissue disorders can also cause, it cause a lot of etiology, like it can cause myocarditis, ischemic heart disease, pericarditis, which contributes to heart failure. So coming to epidemiology, it is estimated that 64.3 million people are living with heart failure worldwide. And you can see this diagram, prevalence of heart failure increases with age. As we grow, the tendency for heart to decompensate increases because it's a part of degeneration. And at 55 years of age, the lifetime risk of heart failure is 33% for men and 28.5% for women. And regarding incidence, you can see prevalence of Indian population is on 0.12 to 0.44%. And these are the various incidences. India is also standing here. So, but I think this number is very fastly increasing because India, because of high rates of diabetes and hypertension, and also with post-COVID status. And India, I think these are the old statistics. I think the number would be more. So the basics, the signs and what is the signs and symptoms of heart failure? You can see the common symptoms of heart failure would be dyspnea, means shortness of breath, or orthopnea, means breathlessness on while lying down, and PND, or we classically call as paroxysmal nocturnal dyspnea. What is this? How different it is from orthopnea? So orthopnea is more severe form of dyspnea. We grade it. Before that, a stage comes called PND. So when how the typical PND episode is described is when the patient lies down during the night. After 2 to 3 hours, he suddenly gets up with sudden cough, breathing difficulty, and pulmonary edema, and he has to get up, and sometimes he has to stand and go to the window and breathe. There will be severe hunger of breath. So this may last for 1 or 2 hours, and this classically doesn't set in immediately after lying down. Generally, because of pooling of blood from lower limbs to the heart and the lungs, that will take 2 to 3 hours. That is a classical difference between orthopnea and PND. Orthopnea is severe grade of dyspnea that comes after PND. Orthopnea is patient having dyspnea immediately after lying down. And because of reduced cardiac output, they can have exercise intolerance. Because of decreased cardiac output, there's decreased blood supply to the muscles, all the organs, that may cause exercise intolerance. Fatigue, that is same as I described, because decreased cardiac output. Patient will have ankle swelling or pedal edema. Because of this, he will have weight gain because of fluid retention. He may have more nocturia. And because of pulmonary congestion, he may have nocturnal cough. And puffy face in the morning because of lying down and getting up because of cooling of fluid on the face and legs. And bendopnea is shortness of breath while leaning forward or bending forward. That is also one of the different aspects of dyspnea, but that is also that's a spectrum of dyspnea. And coming to the signs, what are the signs we should look for, especially in the ER or in ICUs? Nursing staff can also look for these signs. If doctor is also very important, but these are the basic things with sister staff can be alert and look, and also alert the clinician. Elevated jugular venous pulse, as you never know, we generally look on the right side of the neck for elevated jugular venous pulse. And also hepatojugular reflex. This is just when there is subtle heart failure. To evaluate the JVP, we generally give a hepatojugular. Just compress the abdomen or the epigastrium for a few seconds and see when there is raise in the jugular venous pressure. So on auscultation, you may hear gallop rhythm, that is third heart sound, and also by palpation you can look for cardiomegaly, I mean enlargement of the heart. So patient can, if the patient is in heart failure, I mean acute decompensation, patient could be can be in tachycardia, that is high heart rates, tachypnea, that is fast breathing, and also there can be, you can palpate the abdomen, you can feel for hepatomegaly. The hepatomegaly is just enlargement of the liver because of congestion, because of right heart failure. Like the pedal edema, fluid may collect in the liver and it can lead to hepatomegaly. So pleural effusions, you can see because of congestion, congestive heart failure, there could be collection of fluid in the pleural spaces. It could be bilateral. Most commonly, we expect right more than left in heart failure, or bilateral most of the times. Pedal edema, you can look for pedal edema, and rails are Ronchi. Because of fluid collection in the interstitial lung spaces, there can be bronchoconstriction. That means sometimes some patients we call it as cardiac asthma. So cardiac asthma is when the patient having asthma like symptoms with interstitial lung fluid accumulation which causes bronchospasm. So they may have a lot of wheezes. So that's why we a lot of patients we suggest along with heart failure management we ask them to put on nebulizations with bronchodilators. You might have seen in a lot of prescriptions. And mitral regurgitation, we can on auscultation we would like to listen pansystolic murmur caused by mitral regurgitation. So these are the basic symptoms and signs of heart failure. And coming to the classification, this is the most common classification which is described. By definition, we generally describe it as left side heart failure or right side heart failure, but most of the times it could be combined. Then we call it as congestive heart failure, and it could be a left side heart failure can be systolic or diastolic. Systolic means patient will have low ejection fraction. The problem with the ejection. Diastolic means the ejection fraction is normal. In spite of that, patient may have, because of stiff heart, patient can land up in heart failure because the stiff heart will not give time and the volume will be less time to eject. So because this impaired relaxation of the heart which contributes to diastolic heart failure. So as I told you, on the basis of EF, we have three classifications on the basis of EF, that is HPEF. HPEF is heart failure with reserved ejection fraction. Now you can see a lot of patients coming to ICUs with normal EF, but patient is having heart failure. Especially we can see hypertensive heart disease, CKDs, liver failure. These cases you can expect heart failure with preserved ejection fraction. You may be wondering why the patient, though EF is normal, patient is having fluid accumulation. This is the reason. Patient will have stiff heart. You may expect concentric LVH with stiff heart, which contributes to HPEF. And second one is heart failure with reduced ejection fraction. In this, the patient will have EF of less than 40%, which contributes to low ejection and heart failure. And which most commonly we see this patients with post myocardial infarction. We expect myocardial damage followed by heart failure with reduced ejection fraction. And heart failure with medium range ejection fraction. This is a new terminology we are seeing since last few years. When the EF is more than 50%, we call it as preserved ejection fraction. When the EF is less than 40%, we call it as reduced ejection fraction. But when it is between 40 to 50, we call as mid-range heart failure. I mean mid-range. This contributes sometimes when the patient is having previously severe LV dysfunction. Slowly, when the EF is improving post revascularization, they may also come and fall in this category, like reduced ejection fraction, improving to medium range ejection fraction. We call them also medium range ejection fraction heart failure. And the basis of time course, we call divided into acute heart failure and chronic heart failure. So acute means patient within 1 or 2 days suddenly decompensate and presents to ER with acute signs of heart failure. Chronic heart failure means when the patient is having chronic etiology like post MI with LV dysfunction with recurrent symptoms of heart rate fluid overload. That is a case of compensated state. Generally more than 3 months we call. And by severity of symptoms, we grade the heart failure into three classes. New York Heart Association classification we call. I'll tell you the different classes and severity graded into four classes: class 1, 2, 3, 4. As I described, these are the basic definitions of left side, right side, and congestive heart failure. So you can see here HPEF more than 50% EF, reduced ejection less than 40%, mid range is 40 to 50. So sometimes in the heart failure spectrum, patient may land up in one of these classes and may improve. Imagine a patient post MI with presenting with EF of 35%, but later revascularization, his EF may come to more than 50%. Sometimes patient previously having good AEF may having re-MIR landing up with myocarditis may fall into low ejection fraction. And also it could be vice versa. Patient may land up in all these three spectrums. So evidence of patient characteristics on ejection fractures. So this is a basic terminology we describe. Patient with reduced ejection fraction most commonly are males. Doesn't mean that females doesn't have this, but percentage wise, males are more predominant, and most of them has history of myocardial infarction. So, and HPF, these most commonly are older females and high rates of atrial fibrillation and hypertension. So HPF you most commonly see highest percentage is seen in females, older patients, those who are fat, and those who are risk factors of diabetes, hypertension, and atrial fibrillation. Okay, it doesn't mean that females should not have reduced ejection fraction or males should have only reduced ejection fraction. So it is interchangeable, but predominantly it is described like this. So classification based on time course, as I told you, chronic heart failure generally more than 3 months old, and body adjusts to decrease in cardiac output to compensatory mechanism, which results in systemic congestion. These patients you can see coming to the OPDs with the fluid overload, but patients may be not having any dyspnea. That's a kind of decompensation. Body is trying to compensate with systemic congestion so that patient doesn't have much of dyspnea, and they come to follow up in the OPD. And its acute decompensation is sudden decrease in cardiac output, which results in rapid decrease in tissue perfusion. These patients land up in emergency departments and get admitted into the ICUs. And more, there are some triggering factors which can leads to acute heart failure when the patient is already having low ejection fraction. Factors like sudden onset of fevers, sudden onset of atrial fibrillation, or some kind of small trigger or any lower respiratory tract infection may contribute to chronic heart failure decompensing into acute heart failure. Any small tip in the or any trigger or stress can lead to acute heart failure. For when the patient having chronic heart failure with compensation. So this is the severity of New York Heart Association classification. Class 1 to class 4. Class 1 is minimal. Class 4 is very severe. Okay. Class 1 means patient having physical activity is not limited because of HF, and no symptoms of heart failure. So the basic class, it's not, I mean, patient can do his activities, not limited. And class 2 is there is slight limitation of physical activity. Generally, you can see patients coming now when I'm climbing stairs, having dyspnea. These kind of patients come into category 2. Okay. Class 3 is a marked limitations. So with just a movement, I mean, a few steps, they become dyspneic, and they are very comfortable at rest. When you ask them to move a little, I mean, you may be seeing in the ICUs when they ask the patient to go to washroom, he'll be what you call saying that, sir, I can't walk. So these are the patients with class 3 NIHA. Okay. What is class 4? Class 4 is very severe form in which patient at rest, in spite of being at rest, he will have dyspnea. These generally acute decompensated heart failure. Okay. These are the patients which require oxygen, NIV. Sometimes they go on to ventilator also. So generally they present with acute pulmonary edema. So you have any doubts regarding these 4 classes? Is it clear? So generally cardiac dyspnea is graded as NIHA classification 1, 2, 3, 4 symptoms. So these are different staging of, I mean, clinically, I don't think it's very nursing point of view, not, I mean, clinician may benefit from this classification, but for completion sake, we just try to note down this. So heart failure staging is classified into 4 stages. Stage A, same thing. Stage A is milder form. Stage D is severe form. Stage A means high risk for heart failure, but no structural heart disease or symptoms of heart failure. These category A, stage A, are the patients with risk factors like hypertension, diabetes, but they don't have structural, they have structurally normal hearts, but they are at risk for heart failure at any moment of life. Okay. So this is graded as stage A. Stage B is patient will have some kind of structural heart disease like any valvular, myocardial, or pericardial, but they don't have any symptoms. You may be seeing a lot of patients with reduced ejection fraction, but they never had heart failure. So this category of patients come as stage B. Stage C is they will have structural heart disease and also they will have heart failure symptoms both together. So this is stage C. And stage D is refractory heart failure requiring special interventions. So stage D is very difficult form of severe heart failure where patients comes with recurrent heart failure admissions in spite of using multiple what you call diuretic agents, inotropic agents. Patients will have low blood pressures, and these patients require special interventions like during procedure of, during acute MI, they may require mechanical circulatory support kind of picture like IABP or ECMO, Impella. These kind of intervention people may require. Okay, the stage 4 is very severe and it is high risk category. Patient may and high mortality. So, but there are different, there are mimickers of heart failure. Mimickers means the presentation, you can see a lot of patients presenting with dyspnea, but there are a lot of reasons other than cardiac for dyspnea. There could be causes like respiratory causes like pneumonias, asthma, COPD, and sometimes it may be difficult to differentiate at the initial presentation. Is it because of heart failure or is it because of acute severe asthma? Or, so that's where our evaluation is needed to differentiate cardiac from non-cardiac reasons. So you can see COPD, bronchitis, cirrhosis, or CKD, which may present with like this. So how to diagnose a heart failure? So most important thing would be, I call history. History is very important. We should take a detailed history of the patient, past history, clinical history, and also his risk factors, which help us in putting differentiating cardiac causes, non-cardiac causes of heart failure, and also sometimes there is a thin line between respiratory and cardiac causes. So you should be very alert to differentiate both of them. Physical examination, as I told you regarding the signs, basic blood estimations like blood panel, ECG, chest X-ray, echocardiography, and biomarkers like NT-proBNP, troponin. These may help in differentiating and classifying heart failure severity also sometimes. So algorithm for diagnosis of patient with chronic heart failure. As I told you, first is signs and symptoms of heart failure. You take the proper history, physically examine the patient, evaluation, which these are the points to be evaluated: the basic blood panel, ECG, echo, and biomarkers. And depending on that, you should look if it's, all these points are pointing towards heart failure, then you classify it as reduced ejection fraction, mid-range ejection fraction, or preserved ejection fraction. And if you are still not sure, in spite of taking history, symptoms, and signs, and doing a basic evaluation, if you are not certain that it is heart failure, explore for alternate causes. As I told you, respiratory causes, metabolic reason, anemia, and CKD, all those to be ruled out. So this is just a research and clinical criteria of heart failure. Not very much. I mean, most commonly we use Framingham's criteria only, and it's well validated with high specificity. So what is Framingham's criteria? It is not much different what I told you regarding the signs and symptoms, but to be objective, and it's been divided into major and minor criteria, which, I mean, depending on the clinical statistics, they classified the symptoms and signs to major and minor. And major criteria would be acute pulmonary edema, cardiomegaly, hepatojugular reflex, neck vein distension, PND, as I told you, Rales, and third heart sound. So when these major criteria are there, you are certain that patient will having heart failure. And minor criteria would be ankle edema, dyspnea on exertion, nocturnal cough, hepatomegaly, tachycardia, and pleural effusion. These are also contributors, I mean, which give evidence of heart failure. But more than, I mean, according to the statistics and clinical research, some points, I mean, major criteria are the ones which give us clues to definite evidence of heart failure. So coming to evaluation of heart failure, As I told you, history, examination, and basic evaluation. And if you suspect heart failure, do echo, label the EF, how much EF the patient is having, and treat according to systolic or diastolic heart failure. And if Framingham criteria is not met or with normal BNP levels, systolic heart failure is ruled out, suspect diastolic heart failure, and come out and next perform a 2D echocardiography. If you don't suspect a heart failure, you should look for any alternative cause. Again, this would be, I think, I call it as mild repetition of the older one. I mean, previous slides. So symptoms or signs you look at for, and if the symptoms of alternative causes, I would stress on this slide because already we have went to the physical examination findings. You look for the blue boxes, and generally to differentiate cardiac versus non-cardiac, if the patient is having severe abdominal distension of hyperosplenomegaly, tender ascites, sometimes you can give clue for liver disease like cirrhosis of the liver. And if the patient having pedal edema and there is joint inflammation, painful joints, suspect any rheumatological disease like rheumatoid arthritis. And if there is predominantly wheezing without much of Krebs, suspect pulmonary disease. And if there is, you can see large swelling at the thyroid megaly or thyroid nodules, try to rule out thyrotoxicosis or hypothyroidism. And skin, look for cyanosis, anemia, jaundice, which may give clues for anemia and liver failure. So the blue box which helps to rule out any alternate causes other than heart failure, which contributes to symptoms and signs which may mimic heart failure. So I think we have the routine panel. You might be all knowing what we are ordering in our ICUs and ER departments. CBC, urine analysis to rule out any renal causes, electrolyte levels routinely because patient will be having is using diuretics, and also can be patient presents with lot of times with hyponatremia, hypokalemia, and fasting sugars just to see for any high sugar levels contributing to acute heart failure. Lipid profile as a routine panel to screen for the risk factors. TSH for hypo and hyper, and look for calcium and magnesium because while using diuretics you may expect hypocalcemia and magnesemia, which may cause to ventricular tachycardia, ventricular fibrillation, also AF metabolic panels to be ruled out. Creatinine and blood urea nitrogen we routinely do. LFTs to rule out any what you call causes of liver failure. And also one of the mimickers is patient will having high SGOT, SGPT. You might be seeing patient of heart failure with a lot of congestion causes congestive hepatitis. They present with acute decompensation. You can see raise in LFT. In that patient, you should be very careful to evaluate. It may be not liver failure, but it's a secondary reason of heart failure. I mean, secondary factor which may be primarily caused by heart failure, because when there is congestion in the liver, there is congestive hepatopathy which causes OTP2 to rise, so SGOT and SGPT. So we call it as congestive hepatitis. It is not a primary liver disorder, but it is secondary to liver congestion caused by heart failure. Coming to the evaluation, heart failure evaluation is not complete without looking for ECG. Okay, so 12 lead ECG is very mandatory, and we cannot, I mean, ideally we should look for 12 lead, not the 3 lead or 6 lead. And normal ECG may exclude heart failure in nearly 90% of the cases. So ECG will give some clue regarding the etiology of the heart failure. So what are the clues which can pick up on the ECG? So this is a normal ECG. You can see it's a very normal P wave, normal QRS, normal T wave here. And you can see the difference between normal ECG and patient is present with CHF. I mean, this patient has poor R wave. You can see R wave is very much preserved here. You can see there is no R wave at all. And there is deep QS complex. Maybe patient will having old MI, like anterior MI, or depending on the leads distribution. So this may give a history that patient may be having old anterior MI, which is causing his heart failure. So what are we are looking at ECG? So you may be also having ECG classes previously at your basic nursing level to look how to read a basic ECG. So we look for heart rate intervals, most commonly PR interval, especially which is important. The PR interval is prolonged. We expect the patient to be in heart block. Okay. And QRS duration and voltage. As I told you, you can compare the voltage on this side and this side, and we can assess what could be etiology. QT interval. QT interval means is a Q wave and is a T wave. So peak to peak, this is called QT interval. With this, sometimes patient we expect if the QT interval is very much prolonged, they are more prone for ventricular tachycardia and ventricular fibrillation. And this is very important while giving describing some of the drugs. Pathological Q waves, as I told you here, indicates there will be old MI. Okay, left atrial overload. P wave are the evidence of seeing for atrial overload. P wave is contributed by atria. So if there is any atrial load because of heart failure, there can be abnormal morphologies of P wave. So next LVH, when a patient is in hypertension, you can look for high voltage ECG pattern, and also bundle branch blocks may give clue to patient with hypertension or bundle branch blocks will give, infiltrative disorders had to be ruled out. So I think you have understood some basic points about ECG. Okay. So next comes the chest X-ray, which is most commonly performed. Okay. And you can see here what are the things to looked out while seeing X-ray. This is the cardiac shillette, cardiac border. This is cardiac border. This is the both lung shadows. Okay. And this is the pulmonary vasculature. This is the area of pulmonary vasculature. Okay. So when cardiothoracic ratio, ideally it should be this. This is a lung over panel. In this, from here to here, if the heart occupies more than 50% of distance from this border of costophrenic angle to this costophrenic angle, then we call it as cardiomegaly. Okay. And cardiomegaly means there is cardiac enlargement that gives a basic sense. I mean, in the peripheral centers, if you don't have any echocardiography, and some simple ECG and echo can give clues to if they suspect any heart pathology. When the patient is having valvular heart disease, you can expect atrial enlargement, severe left ventricular enlargement in severe hypertensive heart diseases that may give clue. So X-ray you cannot, X-rays also becomes very important, especially in peripheral settings. And when the patient is having acute pulmonary edema, you can see here compared to this X-ray, you can see there is infiltrates both sides. Okay, we call it as batwing appearance because of pulmonary venous congestion. This white is infiltrates. These are the pulmonary vasculature, interstitial lung edema we call. So with this, when the patient is having pulmonary edema with venous congestion, you expect this kind of X-ray. So it's easy to diagnose heart failure by just looking at the X-ray. And bilateral pleural effusions means both costophrenic angles are filled with fluid, and you can this patient doesn't have any pleural effusion, but you expect pleural effusion to be on this side and here. Okay, this both gaps will be filled with radio opaque shadows. And pericardial calcifications, if the patient is having constructive pericarditis, on X-ray you can look for any pericardial calcifications. And also if there is large pericardial effusion, you expect a cardiomegaly also. So X-ray also contributes to understanding some kind of etiology of heart failure. So after the X-ray, we see in lot of ICUs, intensivist and also emergency doctors performing lung ultrasound. So what does lung ultrasound and how does it help? So when the patient is having pulmonary edema, before X-ray is done, if you have just a small probe of ultrasound, you can just screen the lung spaces. So if you find curly B lines on the ultrasound, that indicates the patient is having pulmonary edema. And also you can, by ultrasound, you can also see for any effusions, pleural effusions, and also size of the, is it mild, moderate, or is it severe? If it is massive, you can appreciate in the X-ray, but if it is mild, sometimes it may miss in the X-rays. So ultrasound can pick up even mild amount of also pleural effusions. So echocardiography, as I told you, it's very important uh, uh, test to see the etiology of heart failure. I mean, what are the problems from outside to inside of the heart? That is, echo can see pericardial diseases, myocardial diseases, and valvular, that is endocardial disease. We can see the heart by ultrasound and see what is the problem, what is the EF, how are the valves, how is the pericardium. So it gives basic idea and label the heart failure etiology. And most of the times when I ask sister how is the echo, they generally say, sir, EF is 60%, EF is 40%. I'm also telling lot of staff to EF is not the only criteria you should look in the echocardiography report. There are a lot of other things which are mentioned in the echo report. You should go through the all the points. There is a almost 10 to 15 points, but you look at only the EF. So sometimes patient may be having severe aortic stenosis and EF is normal. EF normal doesn't mean that patient has structurally normal heart. Okay, when I'm going for rounds, when I'm going for doing cardiac fitness, I asked the sisters, how is the echo? The most common reply I would get is, sir, EF is 65%. So overall, you have to see overall what is the report. Okay, because there can be problem with the valve. When the patient, I cannot give a clearance if the patient have normal EF, but patient is having severe aortic stenosis or severe mitral stenosis, or patient is having failure with preserved ejection fraction. As because EF doesn't mean patient is not in heart failure. As I told you, there is a component of preserved ejection fraction heart failure. Okay. So echocardiography, there are different levels of echocardiography. Transthoracic routinely performed, transesophageal generally like endoscopic echo. It's we generally do in the echo room. So by why we have to do a transesophageal echo? Why not a transthoracic? Does transthoracic echo will not give all the data? I mean all the information we need. Sometimes yes, I call it as, because sometimes you need to see decision making, some of the structural components of the heart which may be not evident and transthoracic, because transesophageal means you are going behind the heart and you're looking heart very clearly, because transthoracic means we are screening through the chest wall. The image may be not clear and some of the structures may be not evident on transthoracic echo, especially congenital heart disease like small ASDs or small VSDs. And if there is small vegetations like infective, and when you're suspecting infective endocarditis, vegetations may be not very clear on transthoracic echo. And also small thrombus. Sometimes we may miss thrombus, especially in the LV apex. If there is small, sometimes we may miss it. And also left atrial appendage thrombus. So some they cannot be screened through transthoracic echo. So transesophageal, depending on the requirement, we have to order for transesophageal echo. So stress echocardiography, generally this also we not for all the patients, we perform. Patients look for you might have seen sisters, lot of patients with cardiac fitness coming with dobutamine stress echo report to you in the wards. So what is dobutamine stress echo? Is just like a stress echocardiography. It's a kind of when the patient is not able to do a treadmill test, so we order for a dobutamine stress echo. Okay, when the dobutamine stress echo is normal, that means that in spite of pushing the patient with to high heart rates by stimulating with dobutamine, when the patient EF is normal and doesn't have any problem with high heart rates, include when giving dobutamine, that means patient is tolerable to undergo anesthetic or surgical stress. That's why we give fitness. If the patient is not able to do a TMT and we suspect some problem, we generally order for dobutamine stress echo. So these are the echo modalities and various parameters we look for. You can see LV myocardial function, LV desynchrony, any valvular regurgitations. I can see a large left atrium here, and also LV thick LV, and also tricuspid regurgitation. So these are the various parameters what we look. Other than echo, we see lot in the echo, and you should understand that other than EF, there are other lot of things to look at. That is the reason for giving this slide. Coming after doing ECG, echo, and chest X-ray, what are the other parameters to look at for labeling the patient as heart failure? So these are the biomarkers. These are blood panel what we do. So most commonly you see we order for a BNP or NT-proBNP. Most of the times in the ICUs and also in the ER. So what are the cutoffs and what is BNP and also NT-proBNP? As per European Society of Guidelines for clinical purpose India, a BNP value of more than 500 and also NT-proBNP of more than 1000 picograms suggests there is a possibility of heart failure. And what are the role of NT and proBNP is to rule out heart failure. If the values come less than this, it is unlikely that patient will have heart failure. And to assess short-term prognosis, if the BNP value is very high, so if the BNP value is 1200 and patient is heart is not under severe stress, when the patient BNP is around 10,000 or 20,000, that means heart is under severe stress and releasing lot of biomarkers from the heart, means heart is under severe stress. It indicates prognosis is not good. So long-term assessment, discharge BNP is also important. When you admit, you get a BNP levels, you stabilize the patient and order for a discharge BNP. When the BNP comes less than 25% of the admission BNP, it means you have stabilized the patient very well. And also to guiding therapy, you may be giving lot of heart failure medications to the patients, and when he comes for the follow-up, you assess the BNP, how is BNP increasing or improving. So you can adjust your diuretics, beta blockers, ARNI, and SGLT inhibitors like now we are dapagliflozin, ARNI like Vimada, Sigmas, what we commonly use it. So depending on this, you can adjust the our heart failure medication depending on the BNP level. So it helps in diagnosis, prognostication, and also tailoring our therapy. So BNP has sensitivity of 70% and 99% specificity, and NT-proBNP has 99% sensitivity and 85% specificity. These are the statistics. I don't think much helpful for you. This is a small note. You can see in the gray box here, BNP levels can be reduced in certain circumstances. Sometimes there can be false positive or false negative BNP values. So BNP values can be low in patient obesity and also African Caribbean origin, because we see a lot of in Medigor we see a lot of Somalian and South African patients. So we should keep this in mind. And also when the patient is on diuretics, AC and ARBs, you expect there is some fluctuation in the BNP. So this can alter the positive or negative predictive value of the BNP. So other diagnostic tests that can aid diagnosis of heart failure are angiography. You may be routinely seeing coronary angiogram, we order for, or myocardial biopsy and cardiac catheterization. So angiography is to rule out any ischemic heart disease. Patient may have any coronary artery disease. We look for any blocks in the coronaries, and is it the reason for his LV dysfunction or poor ejection fraction? We want to address or not, we have to rule out with coronary angiogram. Next comes the cardiac catheterization. Look for any pressures in the heart, and also myocardial biopsy. Sometimes when there is no CAD, we should look for any other infiltrative or cardiomyopathies. In that cases, we are myocarditis. In that cases, we generally do a myocardial biopsy. We take a biopsy from the heart and send for the histopathological examination to find the etiology. We generally not routinely perform this biopsy. Only after doing extensive investigation, we are not coming to a clue, then we order for a biopsy. So left ventricular angiography, and previously they were doing this, but nowadays we are not, because with echo predominating the things, we are not doing left ventricular angiography routinely. And MRI. After echocardiography, you see a lot of post-MI patients. We might be ordering for a MRI, cardiac MRI for looking viability, because MRI is a better predictor of viability and also estimating the ejection fraction. because echo is very commonly available. We generally do it with echo, but when you have doubtful viability to treat the patient with a stent, or when you are going for a CABG, if you have a doubtful viability on echo, kindly order for a cardiac MRI to look for viability. And also you can see tissue characteristics, like like I told you, cardiomyopathy is like you may be seeing hypertrophic cardiomyopathy, infiltrative cardiomyopathy can be better assessed with cardiac MRA. And cardiac CT can be also useful. You can be seeing a lot of patients coming for admission after doing a coronary angiogram, I mean a CT coronary angiogram, to look for any coronary artery. This is just a counterpart of cath coronary angiography. And this is a high-end nuclear imaging. This look for viability and infiltrative lung disorders. So when we are not sure with echo and MRI, next we'll going to, according to the patient's clinical data, we may order for a nuclear imaging like SPECT scan, PET scan, MIBG scan. These are out of, I mean, not very helpful for you. Just for completion sake, I have put this. So here comes the ending slide, and these are the key takeaways of our today's topic. The burden of heart failure is likely to increase with time, but effective treatments that improve quality of life and survival are available. Accurate and timely diagnosis is crucial to ensure patients receive appropriate treatment and avoid hospital admissions. However, diagnosing heart failure can be difficult as symptoms and signs commonly overlap with other conditions, which we have discussed well elaborately. A chest X-ray can be useful to identify evidence of heart failure or other lung pathology. However, normal result does not rule out a diagnosis of heart failure. ECG is often abnormal in patient with heart failure, although 10% of the patient will have normal ECG. Sometimes ECG can be unremarkable, but in these cases, we should look for other evaluate other parameters to rule out heart failure. Biomarkers like natriuretic peptides will also help in ruling out and tailoring the therapy for heart failure. And these are the basic heart failure classification, evaluation, and also parameters to look for etiology of heart failure. So thank you for your attention. I hope I made you understand some part of the heart failure etiology. If you have any questions, it's open for questions. If you didn't understand any points which I spoke, you are free to ask any questions.
Any questions? Rajesh, ICU team, critical care team, ER team. You have seen many cases landed up with heart failure, right? ER, Naresh, Rajesh. Even early morning, when you don't detect early morning warning signs, patient may lead into heart failures. What is the causes behind that? And what must be, you may have some trigger points in your mind. Please feel free to ask questions to sir. They're here to give knowledge, not only giving lectures. Please use these podiums to ask questions. Day to day you see many cases, especially in cardiac centers, landed up with many cardiac dysarrhythmias, dilated cardiomyopathy, cardiac heart failure, congestive heart failure, a lot of inotropic support, which heart is not pumping blood, and patient may lead into, especially early morning cardiac arrest, may leads to heart failure, ventricular tachycardia, atrial fibrillation. Hypovolemic shock. It was so informative session. I think my nurses in morning hours, I don't think so you're sleeping. I think it was so informative, and he put into nutshell and nurtured us with anonymous knowledge about heart failure. It is not basics. It was evolved with lot of clinical practices. So try to utilize this platform. If you don't have questions now, at least you post questions later in the interval. Also, you can ask when you have break session. Push up your mind, and because day to day we are practicing 24/7. You are at bedside, and cardiac patients how it leads, and especially when you are dealing cardiac rehab patients, a lot of patients comes with cardiac arrest. You have seen many contraindications post angiogram, post PTCA or post CABG. especially elderly aged group, geriatric patients between 60 to 70, and winter seasons, you have seen many patients landed up with heart failure, walking to year. No questions? Please speak up, my young nurses. If you don't have question, I'll ask you, Rajesh. You want to ask? Yeah. Can you pass the mic? Yes.
Rajesh.
Good morning, sir. Thank you so much for enlightening us with all the basic and important points which we cannot refer anywhere. Uh, like you said, no, sir, like preserved ejection fraction heart failure patients. Like we know that for severe LV dysfunctions or heart failure patients, we mostly be restrict fluids. Either it is orally or IV fluids, like a limit of 1.5 or 2 liters per day. In case of preserved ejection fraction, where they have 60% of ejection fraction, can we advise to give fluids? For example, sometimes they may have hypotension, dehydration, IVC, collapse, or something like that. So in such scenarios, thinking that taking the picture, like you said, it's most commonly when it comes to echo, ideally we go for only EF. 60 means, okay, we can just flush fluids. But patient might be having preserved ejection fraction heart failure. In such scenarios, can we advise to give fluids according to the scenarios?
So when the patient presents with acute heart failure and he has preserved ejection fraction, you take that as one scenario. When the patient is stable and he has previous history of admission with preserved ejection fraction heart failure, that is another scenario. When the patient is having acute heart failure, you are not supposed to push any fluids in acute stage. Okay. But when there is patient admitted with, I mean, previous history of heart failure with preserved ejection fraction, and also is not in a decompensated stage, and if we feel that there is hypotension, even with severe LV dysfunctions, sometimes when suddenly patient going to hypotension, we push a bolus of 200 to 300 fluid. So you have that liberty to just sometimes, because we put them on a lot of diuretics and other drugs which may cause to hypovolemia. So in that cases, you can give a short bolus dose of fluids and improve his blood pressure. So fluid restriction definitely is also indicated in heart failure with preserved ejection. EF because the patient cannot take the fluid which are, I mean, the stiff heart and abnormal relaxation of the heart. Even if you push fluids, that may cause pulmonary venous congestion. Okay, so the patient is not able to hold whatever fluid he has. That is the reason. Okay, the pathology is different, but the what do you call, the fluid mechanics, everything can be same. I mean, patient cannot tolerate such even small amount of few times we see a lot of patients with keeping as 1.5 liters. Recently we came across one patient, we did a impella case, Venkatram Reddy garu. So he has normal ejection fraction. He was not even tolerating I mean 1 liter of fluid. Okay, so in spite of putting him on 1 liter, he is having severe fluid overload. We have to dialyze him 4 to 5 times because he's severely fluid overload. In spite of normal ejection fraction, he was not able to tolerate, and he was very much fluid. Even we required 3 to 4 ultrafiltrates to remove his water. Okay, so when the heart reserve is very poor, I mean, heart is not able to adjust the diastolic stress. So in that cases, definitely fluid restriction is mandatory, and according to the patient's hemodynamics, we should order for restriction of fluids.
We had a case like evolved antiviral with severe LV dysfunction. So it the etiology is like ischemic reason, ischemic cause. So if we revascularize or reopen the vessel, can she turn into acute heart failure, or she improve her EF?
That's what I'm saying. That depends on how severe is the insult, how massive is the MI. If the patient has a massive anterior wall MI and has patient doesn't present within the window period of revascularization, they have, you are telling it is already evolved.
Yes, sir. She
And
came after
was it
1 or 2
thrombolized?
months.
Was it thrombolized in time?
No, sir.
So already she might have crossed the window
Yes.
period. And in these kind of cases with low ejection fraction, you should echo wise we should look for what is the thickness of the myocardium.
My God.
Okay. And also if you are not satisfied with echocardiography, and you should order for a MRI for looking for viability. If MRI wise and echo wise, if there is a viability, then you can do a angiogram. If you find a lesion, you are supposed to revascularize the lesion. So depending on the, sometimes patient may have going into cardiac stunning, we call. There is a concept called hibernation and stunning. Okay, sometimes patient may be in hibernation, sometimes it may be in stunning. So sometimes post revascularization, you have a period of almost, sometimes the patient may improve depending on the myocardial insult. They may improve in 1 week. Sometimes it may take 1 month,
Months.
sometimes 3 to 6 months also. So at least you should give few months of time for the heart to recover post revascularization if it is viable. If it is not viable, it's unlikely revascularization will help. So you should put the patient on heart failure medications, which will preserve or prevents the remodeling of the heart and further worsen the EF.
Sir, one last one. In such scenarios, like you advised a cardiac MRI for viability, in that we see a different number of EF. Like for example, in echo, normal echo, we have 30% of ejection fraction, where it we see in cardiac MRI it given like 15%, 12% sometimes. So which is more accurate? Like because it's half of it, so it's very a low EF.
I understand echocardiography is a subjective, what do you call, report. Okay, echo is done by different operators. Sometimes if I I do a echo and immediately another operator does an echo, there can be variation of 5 to 10% of most
Yes.
difference in the ejection fraction. So echo is a subjective way of estimating the ejection fraction. MRI and in echo, you may sometimes you may not properly pick up the right ventricular function, and also sometimes if you have poor window, you may underestimate or overestimate the ejection fraction. If the patient is very obese and patient has thick chest wall, so these kind of cases you may not pick up the, estimate the EF properly. MRI is different. MRI gives a better estimation of EF. Definitely MRI is a, and there is no operator subjectivity. So it and volumes are better seen. Estimation of LV volumes are better seen by, because MRI is you can do a 3D and all. So it gives better estimation of volumes and better prediction of EF. So MRI is definitely better tool to assess the EF, and especially to assess the RV function also.
2D echo, we are most of the times we'll be doing a 2D, so two-dimensional. So where we'll take a mode cut at one point. Suppose if you are taking a EF at basal segment, but the apex is kinetic, so then you are overestimating. So that's why usually echo overestimates. So we have to add some fraction. Suppose you have taken EF, okay, usually you'll take at the papillary muscle level, and then if it is around 45 and apex is not moving, we have to decrease some 5%. So then there are some errors in echo. MRI is most accurate because they'll take volumes. Okay.
Cardiomegaly. So what is the time of recovering the pace when the patient, how much time it takes to come back to the normal size?
So cardiomegaly means is it a patient with preserved ejection fraction prior to surgery, or patient having LV dysfunction
LV
prior to
dysfunction,
surgery?
With the valve cases which we have saw, that most of the cases have cardiomegaly. So
So see, there are some errors in estimation also. Most of the times, there are some technical reasons and also pathological reasons. Technical reasons are most of the patients you do a AP film, not the PA film in ICU setups.
Yes.
AP overestimates the cardiomegaly, AP film. The heart's Shiloh check is projected more large compared to the PA projection. Okay, that is also one technical reason. Okay, but pathologically, because we are treating with you are opening the chest and also you are manipulating the heart, there can be some myocardial edema, myocardial inflammation, which may also contribute to that. And most of the valve cases, they already have, when the patient is going for surgery, definitely they will have cardiomegaly prior to surgery.
Prior to
So you should compare the
Previous
chest
to
X-rays
post-
previously done and also post-surgery
post-surgery.
to see any enlargement. Okay, but I think doesn't contribute to much of the clinical diagnosis or clinical decisions. That kind of enlargement post-surgery, other
And-
than pericardial effusion.
Is there any chances of coming back to the normal? It may be irritation of a heart after post-surgery.
That's what I'm saying.
Yeah,
It's very difficult to say
Okay.
how much is contributed by manipulation and how much, and if since we correct the pathology, if imagine we have done a mitral surgery, mitral valve prolapse or severe MR or severe mitral stenosis, they generally have huge left atrium that may contribute to cardiomegaly. That slowly comes down over a period. Okay, not immediately post surgery. So that may take some time. You can see improvement of cardiomegaly maybe in few months, not immediately.
Thank you.
Mm. Mm. Mm.
So he has to go through the process of dialysis and all. So in heart failures, like in such scenarios, we tend to put diuretics.
Mm.
So in that scenarios, they tend to lose electrolytes, electrolyte imbalance.
Mm.
So for example, the patient is having potassium of 2.5 or 3. So we have to correct it. So usually we give a minimum of 200 ml for correction, at least 120 milliequivalents or 40 milliequivalent,
Mm.
because we cannot give it directly. So in such scenarios, what preservative or preventive measures we can take? Because he's on fluid overload, he cannot tolerate. But we have to give the potassium correction. So what preventive measures we can take?
See, most of the times, see, IV corrections are only given in emergencies. Okay, so oral and the patient oral also gives almost similar kind of absorption and correction. Only when the quickness and fastness the IV correction is needed. That only in these kind of cases, if the patient is having in severe hypokalemia, you can give a 20 milliequivalents in 100 ml or 50 ml for a period of 1 hour. Which, and also you can cut down his oral fluids when you are giving
Okay.
IV fluids. You can cut down his other requirements, other fluids. So it's basically a fluid management. You can adjust according to that. So in this case, I have seen he was given 100 ml of NS with ferric carboxymaltose. Suddenly he developed heart failure. He was in archiving and 100 ml of fluid with iron dextrose was given. So he could not even tolerate 100 ml. So these kind of cases you should be liberal. I mean, you should be very strict enough. So you should give fluid over a period of, generally you give over half an hour, but these cases you should have given over a period of 2 to 3 hours
Short.
slowly.
Long.
Drip rate should be adjusted, and you can cut down other oral fluids.
So in that scenario, sir, can we put them on potassium sparing drugs? So OD is enough or BD?
Yeah, definitely. He was on potassium sparing drugs.
So OD will be enough, sir.
Yeah, depending on
electron
diuretics, there is pros and cons of diuretics. Sometimes, if you give over diuretics, patient may go into hypovolemic shock. I mean, they have hypovolemia, then can have postal hypotension. Suddenly,
Yes,
when the patient gets up, you can see a lot of patients
Hypertension.
having hypotension. So
Yeah.
you should liberally, I mean, strict enough to adjust what amount of diuretics and what kind of diuretics you are using. You can definitely use, already patient would be on alactone or spironolactone in this case. In spite of that, also patient can have hypovolemia.
Yes,
I mean
sir.
hypokalemia.
Thank you, sir.
Thank you, everyone. I hope I have cleared some of the doubts.
Thank you so much, Dr. Damodar. You have enlightened a lot of information. I think my off-screen viewers also got all the answers. If you have still any questions, you can post in YouTube US, so we can take up your questions in post break session. So you are feel free to post your questions on YouTube link, and we are here to answer your questions. Thank you so much, Dr. Damodar. Now I would like to call our second eminent speaker, Dr. Nitin Annarapu. Sir is having 10 years plus experience, and he is a senior interventional cardiologist, and sir is working with us last 1 year. And Dr. Nitin specializes in cardiac care and coronary interventions. He has performed numerous angiograms and interventional procedures, both coronary and non-coronary. He also holds expertise in non-invasive cardiology, including echo, transesophageal echo, pediatric echo, and dobutamine stress echo. Sir expertise in coronary angioplasty, carotid angioplasty, and peripheral angioplasty, IVS and rota ablations and balloon valvotomy, device closure and pacemaker implantations and coil embolizations. His experience, he worked with Nizam's Institute, and he worked with Sunshine Hospitals and Secunderabad. So, sir has presented many paper presentations and publications, cases various national and international conferences, conducted many public awareness programs in various health camps, and he was, if you ask me, sir is the one of the great pillar behind this program, and he was actively involved, and he coordinated with us. Nurses should get some perspective about heart failure, and he has to what heart failures and how to deal with day to day. He's one of the program coordinator behind this screen. So I would like to call upon Dr. Nitin Annarapu take over the podium. Thank you so much.
Yeah, good morning, nursing staff of all medical branches. So today the reason to choose this topic is so your eyes see what your mind knows. So before day in and day out, we treat more number of heart failure cases than any cases of other cardiac complaints. So it's more common than what you see acute coronary syndrome or MI. So because it's a end component of all heart diseases, finally they end up in heart failure. So uh, you may think that heart failure is only because of reduced pumping capacity of the heart, so, but it's not like that. As the Dr. Damodar already explained, so it's because of it may be because of even preserved LV function also. So there are a lot of classifications, that is heart failure with reduced ejection fraction and heart failure with preserved ejection fraction and so many things. So this is the number one cause of hospitalizations across the globe. So then today I'll try to discuss about management of acute heart failure, and then what is the treatment to be given in chronic heart failure in day-to-day OP basis, and then role of rehabilitation. So the most common error in heart failure management is so mostly they will be discharged even before they are completely decongested. So then they will land up in again readmission. So that is the main policy with the most treatment management protocols. So what is acute heart failure? So it doesn't mean that the patient has to be admitted in ICCU. Acute heart failure means rapid onset or rapid worsening of symptoms and signs of heart failure. What are the symptoms and signs of heart failure? Dr. Damodar explained. So there is a rapid worsening that made the patient to
come to the hospital, which is not planned at all. Suppose we have given a outpatient consultation after 3 months, but something happened and he came back after 1 month. That is also acute decompensation. And then some patients may come to the ER and then they'll take some diuretic and they go home. That is also acute heart failure. And then finally, most common and most worsening thing is that made patient to get admitted in ICU, and some patients may be in shock. So this is a most worst form of heart failure. So these three subsets are called as acute heart failure, either ICU hospitalization or hospitalization and in ward, which is requiring diuretic, and then outpatient department, which was unplanned. So what is the importance of acute heart failure? So it's in hospital mortality is 5 to 10%. It's more than even major cardiac surgeries or MI. And then post discharge, most of the patients, 25 to 30% of patients, they'll die within 1 year after getting discharged because of heart failure. And then if you take into consideration rehospitalization, even around 50% of patients, either they'll die or again they'll be readmitted after within 1 year. There are two types of acute heart failure. One thing is first time diagnosed, first time acute heart failure. They were not patients before. They were not diagnosed to have a heart failure before. And then second thing is already patients were diagnosed to have a heart failure, and then they were stable, and then they were on medicine, and then there is a decompensation. So the stable heart failure is called compensated heart failure, and then decompensation, that is, there are two manifestations of acute heart failure. So this causes, already explained by Dr. Damodar. The most common thing is because of primary cardiac. You see, it's a ischemic heart disease, MI, an unstable angina, and some dilated cardiomyopathy, or sometimes cardiomyopathy because of high alcohol intake, ethanol cardiomyopathy, and then some valvular heart disease, arrhythmias. These are the primary cardiac. 90% of cases are because of primary cardiac issues. The other things are because of just pressure overload, hypertensive emergency, leading to acute heart failure. That is HFpEF, heart failure with reserved ejection fraction. And it may be because of volume overload. So excess volume, fluid intake, and then sodium intake, and then drug non-compliance. Patients were not taking medicines regularly, and then high salt intake and those things. And then sometimes it's because of high output. Anemia is one of the reason where, so that because of HB, that is hemoglobin carries oxygen, so oxygen carrying capacity will come down with anemia. So then to compensate it, heart has to pump more. So that is a high output, but that heart will go into failure. And say that other things are even alcohol also falls into this category. Beriberi. So alcoholic cardiomyopathy is called as wet beriberi. Okay, and then any sepsis, heart failure because of sepsis, also because of heart will be normal, but still there is a high output heart failure. The other things are because of other major surgeries and the substance abuse. So then symptoms. Usually heart failure presents because of two symptoms, either forward failure or backward pressure. So heart is unable to pump. So that's why there is a less cardiac output, so leading to hypotension and further symptoms like fatigue, weakness, and then the decreased effort tolerance. And then sometimes patient may have syncope, mostly postural syncopes. And then it may be because of the back pressure. So then actually all the venous return has to go to the heart, and then it's not going. So there is a back pressure. So there is a volume overload in extracellular spaces like lung alveolar spaces, leading to pulmonary edema. The patient will have breathing difficulty on exertion initially, and then paroxysmal nocturnal dyspnea. So where patient can go to sleep, and then middle of the night he'll get up because of breathing difficulty, and then he has to sit for some time. Then only he will be relieved. So there are two types of things. Patient will with bronchial asthma also, nighttime they will wake up because of breathing difficulty, because of wheeze and those things, early morning or 4 o'clock around. But there, so there is no need to sit even then they will be get relieved. But in paroxysmal nocturnal dyspnea means they have to sit for some time, they have to change the posture, then only patient will be relieved. That is the early warning sign of acute heart failure. And then in severe form, even patients will have orthopnea, and then they can't get lie down. So then, apart from that, there is a volume overload signs, that is a pedal edema, and then raised JVP, and even some abdominal fluid over, that is ascites. These things can be seen. There are different manifestations of acute heart failure. All the patients, they may not have a hypotension at the same time and pulmonary edema. So there are these four classifications. The, uh, the first thing is warm and dry. So this is only less, around 5% of the patients may present like this. That means they are warm, pulses are okay, perfusion is okay, there is no hypotension, those things. But and patients are dry, there is no signs of any congestion, of no pulmonary edema also, but still they may have a heart failure. So here it's very easy to treat. Okay. And then the second thing is warm and wet. So where there is a pulmonary congestion, but blood pressure is okay. So the patient will have signs of dyspnea, orthopnea, if you see X-ray, pulmonary edema, and those things will be there. These things are there, but there is no signs of hypotension. The pressures are okay. This is second thing. So this is little better, and this is a milder form, and this is next phase of next grade of heart failure, acute heart failure, so where the mortality around 9%. And then third thing is the hypotension. So there are signs of reduced cardiac output in the form of cool extremities, oliguria, renal failure, some hyponatremia. These things will be there, but they don't have a congestion. That is usually shock type of thing. So this has a mortality of around 23%. And then the most sick form is patient has cold and wet. Cold means there is a hypoperfusion, wet means there is a congestion. So if both are coexisting, is the most severest form of heart failure, and then the mortality is almost 50%. So these patients require both pulmonary edema treatment measures as well as the inotropes. So these things we have to look for, because that it differentiates what treatment to be given. Suppose the patient is dry and warm, the pressures are fine, and then there are no signs of any pulmonary edema. Just simply, you can increase the dose of oral diuretic, whatever the diuretic is taking, just you can increase the dose, that should be fine. And you can send home. And next, the dry and cold. There is a pressures are low, and then no pulmonary edema. So here, just you can give some first fluid challenge you can give. So there may be hypovolemia, hypovolemic shock. So because patients are on diuretics, so there's definitely they will be having some sometimes it's a over usage of diuretics that leading to hypotension. Just to give, you can give a diuretic, sorry, a fluid challenge, and then if patient is fine, it's okay. Otherwise, you have to start a inotrope. And then third thing is classical pulmonary edema. There is a wet and warm. So pressures are okay, but there is a congestion. So most of the patients in hypertensive emergency, so they will present with this. So the patient had an accelerated hypertension, they will be pulmonary edema, and then so how to treat these patients? So there are two things. So warm means the pressures are normal or more than normal. If it is because of hypertension, heart failure, then first thing we have to give is a vasodilator, NTG infusion, nitroglycerin. And then second thing is diuretic. For both, we have to give diuretic as well as the nitroglycerin or preload reducing medicines like nitroprusside or nitroglycerin. Usually we'll give nitroglycerin infusion. If the pressure is high, hypertension predominates, we have to start in nitroglycerin. Even you can give first 100 micrograms bolus and then followed by infusion. Okay. We can start with minimum around usually 5 microns per minute, and then we can go up to 100 also. So every 10 minutes you check the BP and then gradually increase the NTG infusion. And then we have to give a last diuretics. If the patient is having just a normal blood pressure, suppose it's a 100 and 110 by 80 around. So then first treatment should be diuretic, and then very carefully we have to give nitroglycerin. So in both cases, the treatment you have to give is diuretic as well as a nitroglycerin vasodilator. But if the hypertension is there, the first preference is nitroglycerin, and then along with that, you have to give it diuretic. And if the patient is having just normal blood pressure, so then diuretic, and then followed by low dose of nitroglycerin, and carefully monitor the blood pressure. And then the final last thing is wet and cold. The patient is having hypotension and cold peripheries, as well as the patient is having pulmonary edema. So this is the most sickest patients. And then here we have to see the what is the blood pressure. So if the blood pressure is below 90, so then you have to give a inotropic drug, right? So inotropic drugs are dopamine, dobutamine, and norepinephrine and epinephrine. And then, so if the patient BP is not improving, then vasopressors. So vasopressors, they act on the peripheral vasculature. They increase the peripheral vascular resistance. Thereby, they increase the blood pressure. So then that is a vasopressin, somatostat, those things. And then you have to give diuretics. And then if the patient is not improving with these things, then we may consider mechanical circulatory support, like that I'll explain, the IABP and those things. And then the patient is more, blood pressure is more than 90. So then, so again, you can give nitroglycerin in that is vasodilators, and then diuretics, and along with the inotropics. So we have to plan the we'll deal this section then in 3 different settings. So one thing is to be done within first hour, and then what we should focus on the next part of the day of first day, and then the first week. Then what we have to follow. The first hour, our important should be to maintain a cardiopulmonary stability. So then first of all, we have to assess cardiac stability. That is, we have to assess it, is there any cardiogenic shock or not. And then we have to address it. And then we have to assess the respiratory status. So whether he requires any respiratory assistant or not. So after this, we have to go for the decongestive therapy and other things. So the first thing, so what we have to do, if you are posted in a ER, or the patient has come to ICCU first, so then what you have to do is first assess the heart rate and rhythm. The patient may be having, usually the patient will be having tachycardia, and in heart failure, what happens is, so once the heart fails and then there is a hypertension and pulmonary edema, our body will try to compensate it. So there are 2 ways of compensatory mechanisms. One thing is sympathetic nervous system activation. So sympathetic nervous system comes into play, so that causes tachycardia, and then tachypnea and those things. And then the second thing is hormonal activation, renin angiotensin system activation. So that leads to the preservation of the fluid. So then it functions at the kidney. It tries to retain the fluid and sodium in the body. So because it's a compensation to the hypotension. Okay. So once a patient goes into hypotension, the kidney it thinks that it's not getting good amount of blood pressure. So there is a fluid loss. There is no sufficient fluid in the body. So it tries to retain the whatever the fluid is there in the body by retaining the fluid from the that is body. It won't allow the water and sodium to go into urine. Okay, it for some time it will be beneficial, but afterwards it is a counterproductive. So then there will be fluid overload and those things. Okay. So first, usually patient will have a tachycardia, and sometimes they may have bradycardia also. And then you have to see for the rhythm, especially some patients may present with ventricular tachycardia and ventricular fibrillation. So there we have to shock it. And then you have to see the blood pressure, both systolic and diastolic blood pressure taken manually. And then you have to see for the peripheries. So if the pulses are feeble and then the cold peripheries. So then even the sympathetic nervous system leads to the peripheral vasoconstriction. So it want to maintain the central pressure. So it will constrict all the arteries in the peripheries. So that leads to the cold peripheries. So uh, if then we have to see the respiratory rate, and then the patient is having orthopnea or not, and then whether he is using accessory muscles for breathing. And then because if patient is using accessory muscles for respiration, that means he is trying hard, and then he may develop fatigue, and then he may require intubation. The usage of accessory muscles for breathing, even though patient is maintaining saturation, that is not a good sign. That means he is losing his reserve. So that means he requires either an NIV or intubation, that depending upon the patient's severity. And then we have to see for the pulse oximetry saturation. And then if you are clinically good enough, you can auscultate to see for repetitions. So once you assessed both cardiac stability and then pulmonary respiratory function, so then you have to decide if the patient is having blood pressure of less than 90. So that means you have to start inotropes as well, sometimes even vasopressors also. And then if the patient is having more than 90 of blood pressure, so then we have to give. So presently indication is that if the blood pressure is more than 90 and the patient is having pulmonary crepitations, you can give any small dose of NTG infusion, and then inotropes, and then you have to start other treatment. So this is the first step. So in ER, whether he requires inotropes or not. Less than 90, definitely you have to start on noradrenaline. And if it's more than 90, so noradrenaline may not be required, dobutamine is sufficient. And then next thing is what inotropes used in shock. So usually we use more of dobutamine, right? It has to be, dose should be around 2 to 5 micrograms per kg per minute will start. And then gradually every 10 minutes you have to check for the blood pressure, and then if it is not increasing, double the dosage, and then maximum dose to be given is 20, right? And then usually dobutamine will not increase the blood pressure. This is not the drug to be used to increase the blood pressure. Okay, it is only to increase the myocardial contractility, right? That's why if you have to use only if this blood pressure is more than 90. Okay, and then the second thing is dobutamine. So usually in smaller doses, so it has a renoprotective mechanism. It increases renal blood flow, and then usually we won't use much. And then the second inotrope you should know is noradrenaline or norepinephrine. If the blood pressure is below 90, so this is the first drug of choice. Okay, and many of the times we'll use with along with the dobutamine. So because so which one is good for heart, dobutamine or norepinephrine? Yeah. So dobutamine, it increases the myocardial contractility, and also it reduces the systemic vascular resistance. So the systemic vascular resistance is the force against which blood has to pump. So the resistance lower means it effectively pumps. But if you give a norepinephrine, you can increase the blood pressure, but it increases the systemic vascular resistance. So heart has to try hard to pump against that excess systemic vascular resistance. So that is a load on the heart. So if it is heart failure is because of cardiological problem, so then dobutamine is ideal choice. And then, but the pressure is not holding, you can add norepinephrine, but we have to try to wean off first norepinephrine, So then you have to wean off dobutamine. Okay. And then epinephrine, usually it is used mostly after post cardiac surgeries, and milrinone usually rarely used. So these are the inotropes usually we use in ER and ICCU. Coming to the respiratory failure. So the patient is, first we have to see whether the patient saturations are okay or not, and then there is no respiratory distress. If the patient is having respiratory distress, it depends. Suppose the patient is having shock, always first preference is for ventilation. So because cardiogenic shock, they have a lot of hemodynamic disturbances. So then we'll try to sedate, and then early intubation is always better, so that it relieves the heart from excess load. So because if the patient is having respiratory failure as well as a cardiogenic shock, and then he has to take a breath deep, he is trying hard to take a breath. So that again causes some load on the heart. So that's why to better have a control, usually the first thing is elective intubation and mechanical ventilation. And the second thing, if the patient is not that much unstable, so patient is not cardiogenic shock, or else patient is not willing. So the next thing is non-invasive ventilation. Okay, NIV support. And if the patient is having only pulmonary edema, but pressures are okay, so then usually the first preference is not intubation. So usually non-invasive ventilation, NIV. And the patient is has a heart failure as well as some COPD. So then it's better to start with NIV, right? And then patient is not having any respiratory distress, and then you can give just a simple oxygen through the mask, and then we have to aim at saturation of more than 92% minimum. And then if the patient is on ventilator, so then again de-escalation. If the patient is stable, then you can come down to NIV, and then from there to the high flow mask, and then normal routine mask, and then room air. So there is a escalation as well as de-escalation. And then what are the recommendations when to connect NIV and intubation? So oxygen supplementation is required if the patient is having saturation of less than 90% on pulse oximeter. And then ABG, the ABG showing PaO2 of less than 60. So if these two are there, then you have to give oxygen. And then intubation is recommended if there is a progressive respiratory failure in spite of giving NIV, or else the patient is having cardiogenic shock with multiple comorbidities, like patient is having VT, VF, and something. So then it's ET is intubation should be done. And then not when to give NIV support. So in patients with respiratory rate of more than 25 min per minute, usually it's around 12 to 15 is a normal respiratory rate. So if there is a patient is having tachypnea, then we have to consider with a saturation of less than 90%. And then it has to be started earlier, better than waiting for some time, just on face mask. So because hypoxia causes metabolic acidosis. Metabolic acidosis causes myocardial dysfunction. It reduces the again LV function. Okay, we have to correct the blood pressure as well as the oxygen hypoxia as early as possible in ER. So once this is done, the first thing is maintaining BP, and second thing is maintaining oxygen. You take care of these two things, then you have to maintain, think about decongestive therapy. Next, further, what to be added? Yeah. So what are the different treatment modalities available afterwards? So we have given some airway support, and then you have started on blood pressure support. So then comes is diuresis. So there is a congestion. So we have to decongest the patient by giving diuresis, and then you have to start on vasodilators. So morphine is not nowadays, it's not being used. So only thing is nitrates. The most common is nitroglycerin or else nitroprusside also you can give. So along with that, if the patient is not at all passing urine instead of giving diuresis, so then you can go for ultrafiltration. That is the dialysis. Okay. But it's a role of ultrafiltration is controversial. That's why we won't use much unless the patient is too sick. And then we have given a large amount of diuretics. Instead of that, he is not tolerating, then we can go for dialysis. Okay, so this now once the if patient is stabilized with the inotropes and ventilator therapy, then you have to assess for other things. Then we have to send what are the investigations you have to uh, do in ER or just on arrival to ICCU. The first thing is ECG. So because most common cause of acute heart failure is because of the cardiac issue, and it's because of coronary artery disease or some valvular heart disease, you may find out something. So ECG, it has to be done. And then echocardiography to be done to say whether it's a heart failure with reduced ejection fraction or heart failure with preserved ejection fraction. So because the treatment modalities are different. And then you have to do a chest X-ray. That is two things: to assess the severity of the pulmonary edema, and second thing, are there any other diseases, respiratory disease, like some patient may have pneumonia causing a acute decompensation. So or else the patient may be having other COPD. So then there the treatment also differs. So to rule out any other pulmonary causes as well as to assess severity of the heart failure or pulmonary edema, we have to do X-ray. And then sometimes we will do lung ultrasound, that is to see for the severity of the pulmonary edema, and even sometimes we'll do a therapeutic aspiration if the patient is having massive pleural effusions. Sometimes it takes it causes lung collapse, and then if you do the diagnostic therapeutic fluid aspiration, the patient improves drastically. And then so we have to do blood natriuretic peptides, brain natriuretic peptide. So already the Dr. Damodar explained about this one. So whenever there is a heart failure, that is LA stretch or atrial stretch, it leads to the release of this brain natriuretic peptides. Okay, they are the compensatory mechanisms, because so when there is a stretch of the LA, so it releases natriuretic peptide. So this action of natriuretic peptide is to natriuresis. So it causes more sodium and fluid excretion in the form of urine. It's opposite to the renin-angiotensin system. Okay. So then these levels we have to do. One thing is for the diagnosis. Sometimes the patient is a known case of COPD came with severe SOB. So whether it is a cardiac, that is a diastolic heart failure, patient has a hypertension, and then COPD and sudden wheezing, and then patient is having SOB. So if the BNP is normal, that rules out heart failure. That is a COPD or asthma. And if the BNP is elevated, that is a heart failure. Though echo is normal, so it is a heart failure with preserved ejection fraction or diastolic heart failure. That is the one thing. Second thing is, higher the values of BNP, the more prognosis is bad. It indicates the severity. The third thing, it acts as a baseline. Before discharge, again we have to do BNP. So though patient is very, very stable at the time of discharge, the BNP is almost same. That means the patient is not properly treated. So at least 30% reduction should be there in BNP at the time of discharge compared to the baseline at the time of presentation. So we have to do BNP at 2 times. One is at the time of admission, and second thing is day before discharge or on the day of discharge. So then if the BNP level has come down, you have treated properly, or he can be discharged with less chance of readmission. So if BNP is normal, the patient is absolutely BNP is not reduced, even though patient is normal. If you discharge the patient, chance of getting readmitted is very, very high. So these are the things you have to do. Biomarkers, NT-proBNP you have to send, and then along with that, even troponin also. So it maybe it gives a regarding whether it's because of ischemia or not. So, but positive troponin I always doesn't indicate that it's a ischemic heart disease, because even in heart failure also there is a minor raise in troponin I or troponin T. And then regarding blood parameters, apart from these things, you have to send renal parameters. Okay, blood urine nitrogen, creatinine, and electrolytes. So because of most of the times there will be either acute component of kidney injury or chronic kidney disease with again acute raise in renal parameters. And that all these electrolytes also aids in giving treatment. So if the patient is having hyponatremia at the time of admission, usually that is one of the bad signs. The patient getting chance of mortality or chance of repeated hospitalizations are more if the patient has a severe hyponatremia at the time of admission. And then liver function test, you have to send. So these things you have to order in the ERR in ICCU once admitted. So liver function test we have to because it heart failure causes hepatic congestion as well as hypertension causes hepatic shock or acute hepatic failure. And then thyroid hormone is mandatory. Why? Because if there is a hypothyroidism, so there is high chance of fluid retention, and then your diuretic response will be less. If the TSH is elevated and hypothyroidism is there, so then there will be some diuretic resistance. They require more diuresis, and unless you give thyroxine, so there won't be much expected response to diuretics. One thing. Second thing is if hyperthyroidism or Graves' disease, thyrotoxicosis, that is one of the reason for heart failure. So for these two things, we have to do thyroid profile mandatory in a patient with heart failure. And then even you have to do with the PT, APTT also, coagulation markers, because some patients with heart failure, they'll have a hepatic failure. So in liver failure, usually there is a coagulopathy will be there. And you will be giving anticoagulants in heart failure. So then once this is done, so you have taken care of this thing, blood pressure, and then respiratory thing, and you have given some diuretic, and then you order for these investigations. Then the thing is, we have to see for the any reversible causes and what next to do. So identify the reason for the admission, whether it is a acute decompensation, what are the precipitating factors, those things we have to see. So first thing is if the ACS, acute coronary syndrome, then we have to see depending upon the ECG and depending upon the 2D echo and then cardiac markers results, you can say whether it's unstable angina or non-ST elevation MI or acute ST elevation MI. So then you will decide. So with the acute ST elevation MI, patient may go for primary angioplasty. And then non-ST elevation MI, the patient is severe, significantly in failure, still we'll go for a primary angioplasty. But if the patient is not having just significant changes, only unstable angina, usually we'll stabilize with medical treatment and then followed by angioplasty. And then you have to identify arrhythmias if the patient is having AF. So then we have to administer antiarrhythmic drugs. And then sometimes patient may present with acute pulmonary embolism. So acute pulmonary embolism presents with the right-sided heart failure. So there's a pulmonary artery is blocked. Okay, so then RV goes into failure and patient presents with a shock, hypotension and shock. Then you have to give a thrombolysis. And then you have to identify you have to search for any source of infection. And then even you have to see for hemoglobin. So anemia and then raised TLC. And sometimes if the patient had a history of fever and any burning micturition, those things you have to send for cultures and then procalcitonin. Serum procalcitonin, it gives idea about any underlying sepsis. So once this is done, so then we have to keep monitoring the patient in ICCU. So then usually the monitoring and diagnosing the patient as well as the managing the patient, it happens. So simultaneously. We'll be diagnosing why it happened as well as we'll treat at the same time. So then we have to, next thing is to give a diuretics. So diuretics, there is a escalation protocol until the patient is completely decongested, and then there is a de-escalation. So both things we have to do. So usually in a heart failure, there is a gut edema, intestinal edema. That's why though patients who are taking diuretics orally, they won't be absorbed much. Bioabsorbability will come down, and then there won't the effect of the diuretics will come down. So we usually will give little higher dose, but if you give a higher dose, there is a nick. Then it causes hypotension and then kidney injury. We have to balance. So if you give a lower dosages, so then patient will be in pulmonary edema, they will have a lot of distress. And then if you give a higher dose, the patient will go into kidney injury. So that thing we have to balance. So for that reason, usually you have to maintain strict IO chart. And then second thing is, if possible, daily weight monitoring. These are the two things easy things by which we can assess what the diuretic to be given, and then when to increase the diuretic and when to decrease the diuretic. So these two things are, from nursing care point of view, the most important things are daily weight monitoring and then 24 hours, that is hourly strict IO chart. So usually how we give diuretic. If the patient is already taking diuretic, suppose patient is taking a Lasix 40 mg, right? So patient with heart failure, usually that is not sufficient. Either we'll increase the dose. That means to double the dose of the Lasix we'll give. And then in ideal situation, you have to assess urine output after 6 hours. And then even you have to do the spot urinary sodium. So the effect of this diuretic, so we can assess by doing one thing is diuretics causes fluid loss, that is a water diuresis, natriuresis. So it increases the urine excretion as well as it increases sodium excretion. So by assessing these two, we can say whether that dose is waxing or not. So after 2 hours, you can do urine spot sodium. So it has to be around 50 to 70 milliequivalents per liter sodium concentration. And then if you take urine output after 6 hours, then it should be minimum of 100 ml per hour. So if it is not there, if it is okay, then you can repeat same dose. Every 12 hours, you can give the same dose. But if you are not achieved, again double the dose. And then again reassess. So then this is a one way. Or else you can give if it is not effective, usually we'll start with a IV infusion, especially if the patient is having borderline pressures. So usually bolus diuretics, they'll cause little hypotension. So usually we'll give a infusion. So rate should be around 5 to 10 mg per hour in case of furosemide. There are two diuretics available, furosemide, torsemide, right? So compared to the furosemide, torsemide is little more potent, and especially in oral form. If you give a Lasix orally, that effect will be inconsistent. The absorption, bioabsorption is little vary. But in case of torsemide, the bioavailability oral form is more. That's why oral torsemide is better than furosemide. That's why usually we prefer torsemide if we are giving orally. But in IV, efficacy is almost the same, but the dose is required for torsemide is half the dose of furosemide. Suppose if you are giving 40 mg of furosemide, for torsemide is 20 mg. Equivalent dose is half. Okay. So then continue this thing, IV infusion or boluses. Either you can give PD or infusion, and then final aim is to decongest the patient. And if suppose you are giving maximum dose of this furosemide or torsemide, still the urine output is not good. So then you have to prefer, you have to add other medications. So usual loop diuretics, they'll act on the distal convoluted. And then there are other diuretics you should know. Thiazide-like diuretics usually will be metolazone, Zatanix or metos. Usually we'll add on that. So it acts on the proximal convoluted. It is acts on the nephron, but at different levels. Okay, loop diuretics act on the distal level, and then metolazone, it will act on the proximal convoluted tubule, and then spironolactone or aldactone, and then even Eptas or eplerenone. So these acts on the collecting duct. So you can add other medicines. So if you're not achieving your required urine output is not that much. Usually, at least you should get around 2.5 uh, liters of urine output in the first day of giving diuresis in acute heart failure, right? So if you are not achieving that, then you can add metolazone or spironolactone. So these are the usual diuretics we use in a hospital setting. So furosemide. So many times we'll give a bolus in a ER. We can give up to 100 mg of bolus. Okay. So usually, if you give the bolus, it won't act immediately diuresis, but it reduces pulmonary edema. And then afterwards, either you can give IV or infusion or boluses. And then torsemide, and then other things you should know about is metolazone. Metolazone, it causes high chance of hyponatremia. So if you a patient who are receiving metolazone, you have to be very careful. You have to monitor the electrolytes. So thiazide-like diuretics, they cause hypokalemia and hyponatremia. That's why usually we'll give only 2.5, start with 2.5 mg once a day, and then you can increase till 10 mg once a day. Okay, and even for some people on OP basis, we'll give once a week also. So then regarding urinary catheterization, so don't do catheterization for maintaining the IO chart for all patients with acute heart failure. This is not good. The only urinary catheterization is indicated. One thing is the patient is having cardiogenic shock. So there the pressures, whenever the pressure goes down, so that our urine output will come down. So depending upon that hourly urine output, we'll adjust the doses of inotropes. So for that case, it's a catheterization is compulsory. So, but otherwise, in routine heart failure patients, it's not good to put a Foley's catheter. So because the risk of UTI is more and more, and then finally the patients may end up in UTI and as well as urinary strictures. So urinary stricture is very problematic in the long term. So the chance of infection every week per day, it is 3 to 7%. So that means if you have catheterized for 1 week, that means almost 20 to 50% of UTI. So it has to be done only it's absolute necessary, and then it has to be removed as early as possible. So many of the times we found the patients in the ward also being catheterized. So before shifting to ward, either you can remove the Foley's catheter, or else after shifting to the ward, at least by next day, by 24 hours, it's better to remove the Foley's catheter. Most of the times we'll remove the Foley's catheter at the time of discharge, that too after clamping and those things. That is not good. And then what to monitor? So we have initiated. So for BP, we have given medicines, and then for oxygenation part, we have taken care of. And then we have started diuretics also. The patient is improving. Then we have to monitor both in ICU as well as the ward. So then what to monitor daily? We have to monitor daily weight. It has to be monitored early morning after passing first urination, and then before having anything. Okay, so this has at the same time we have to monitor daily. And then if usually it has to weight has to come down until they achieve a dry weight of that person. So dry weight of a person is there is no clear cut guidelines how to calculate that thing. So because we can out of the overall body we can't calculate the muscle mass, and then we can't differentiate what amount of weight is because of the fluid, what amount of weight is because of other things. So, but roughly, thing is the patient has to be off symptoms. The patient has to be comfortable, and then there is no edema. JVP should be okay. There is no edema, and then the patient should not have a orthostatic hypotension. Right. So this is the definition of approximate dry weight for that patient. You have removed the fluid. You are checking weight. At what weight is ideal for him? That is what is the dry weight for him. That means no symptoms of congestion. So he is not requiring oxygen. That is sign of pulmonary congestion. And if there is no abdominal or distension, there is no ascites, and then there is no pedal edema, and then patient is able to walk comfortably, and he is not on inotropes, and then you have to check. This says that there is no congestion, but sometimes we may be giving overdose of diuretic also. So for that we have to check a orthostatic hypertension. We have to take a blood pressure uh, in the standing position. So that means that weight is correct. We achieved correct weight for that patient. Okay, that we have to wait regularly, monitor the weight, and then we have to monitor the fluid balance, that is IO chart, and then renal functions. We have to, in ICCU, as long as the patient is on inotropes and respiratory supports, so it's better to do renal function every day. And then if the patient is receiving ARBs and ACE inhibitors like ramipril, telmisartan, olmesartan, ARNI, that is Vimeda, and these that they are called renin angiotensin system in inhibitors. So if these things are, if you are using, so they cause lot of disturbances in renal parameters, especially sodium, potassium, and then creatinine. So then if the patient is on those things, we have to monitor daily, and the patient is hemodynamically unstable, patient is on inotropes, we have to do daily. But as the patient shift to ward, then we can space it. Maybe you can do alternate day, or if they are normal, even you can do once in 2 days also. And then you have to check vital signs, and then through the echo, we usually will repeat. So you have to see vital signs and body weight fluid balance, and then you have to see for the symptoms, and then so usually invasive monitoring, when to put a arterial line, and then we have to see invasive monitoring in ICU. Usually patients who are in patients with cardiogenic shock, as well as patients with hypotension with persistent symptoms. So then you usually do invasive monitoring by putting arterial line. Otherwise, it doesn't require invasive monitoring. The importance of ABG. So you should read about some ABG components also. One thing is pH. If the patient is having metabolic acidosis, that is not good sign. Second thing is lactate. Lactate is the biomarker which indicates that there is a tissue hypoperfusion. The BP may be normal. You are maintaining BP with inotropes around 90, 100. But how to assess the organ perfusion? Kidney perfusion, we can assess by urine output. Okay. And then other organ perfusion, it will be assessed by, especially liver, it will be assessed by lactate. So if the lactate levels are more than 2, so that indicates there is a tissue hypoperfusion. That is a bad sign. So if the patient at the time of admission has a higher the lactate level, the higher chance of patient getting died. Okay. So ABG, you have to see pH, and then PO2, if it's less than 60 PO2, that indicates he requires oxygen support. And then PCO2 also you have to see. So that is to see for the breathing efficiency, and sometimes the patient may have obstructive sleep apnea also. There PCO2 will be raised, and then lactate. So then this is how frequently we should monitor these things. Physical examination, vital signs, as long as the patient is in hospital, we have to see regularly. But in ICCU, usually first hour will take every 10 minutes, and then in ICCU, minimum every 2 hours, and the once patient is off inotropes, every 4 hours in ICCU, and then once patient shifted to ward, usually will take 3 times in a day. That should be fine. And then body weight and of intake output chart we have to maintain daily, and then saturation we have to see in ICCU, and then natriuretic peptides and cardiac troponin. So usually troponin will send in only ER. If that is normal, usually we won't do it. BNP will send at the time of admission as well as at the time of discharge. Natriuretic peptides that we have to see. And echo is compulsory at the time of admission. It's a it depends upon the patient to patient whether to repeat it or not. And then renal functions in ICCU daily, and then in ward you can space it. It depends upon the patient to patient. Maybe alternative should be fine. So then you have started an Lasix in ICCU, so Lasix infusion and those things, and then when to decrease the dose of diuretic. Okay, in acute heart failure, we will increase the dose of diuretic. We will decongest the patient, and then once the decongested, that amount of diuretic is not required. We have to come down also. So because of the gut congestion in heart failure, there is a gut edema. That's why previous oral diuretic was not acting properly. So, but once the gut is decongested, again the efficiency of diuretic will increase. And then if you continue same dose of diuretics, patient may go into orthostatic hypotension, renal dysfunction. Again, we have to come down. There is a point where we have to stop the infusion, or we have to come down with the diuretic dosage in hospital. So the patient has resolution of the symptoms. So JVP is normal. Patient no orthopnea is able to lie down flat, and then there is no significant pedal edema. Then you have to come down. And then though patient is having not, still there is some JVP is elevated, but still there is pedal edema, but creatinine is increased by more than 1 mg per deciliter compared to the baseline admission. That means that so it is causing renal dysfunction. Then also we have to stop there. So you should not increase. And then if the patient is having still symptom, even you are giving diuretic, still it is not working, then you have to consider for hemodialysis. So the patient is responded well, then you have to come down. That dose we are slowly we have to start a de-escalation strategy. And if the patient is not tolerating, like creatinine is raising, then also you should come down with the diuretic dose. And then patient urine output is not at all, even though you are giving, it's not working, then we have to think of alternatives like ultrafiltration by dialysis. So once patient has achieved dry weight and no congestion and those things, again you have to start a oral diuretic therapy, and along with that you have to start other therapies. Now it's a time to initiate the other therapies like beta blockers, ACE inhibitors, ARBs. You see, inotropes, diuretics, they won't increase life expectancy of patients with heart failure. This is only to stabilize the patient and only to relieve the patient from that at that point of time to save his life. But in future, so if you want to extend his survival, so these are the not the medications. The medications which can improve the quality of life as well as survival of life are beta blockers, ACE inhibitors, ARBs, and these things. So because they'll they affect the progression or natural history of the heart failure. So because in heart failure, the left ventricle, it goes on dilating. Okay, this is called positive remodeling. Okay, So then as the left ventricle dilates and dilates, the efficiency of pumping will come down. Okay. So to effect this or to prevent that left ventricular remodeling, okay, these beta blockers, AC inhibitors, and then mineralocortical receptor blockers, that is aldactone and eplerenone, they are effective in changing the path of heart failure. This is only short term, temporary. These things are helpful in only acute phase. That is to bring back the patient to the before the decompensation state. Okay. And then afterward, at this point of time, once we have given diuretics and is fine, then we have to start slowly those medications, ACE inhibitors and beta blockers. Previously, we cannot give in acute phase because the patient had a hypotension. So ACE inhibitors, beta blockers, they cause hypotension. So once the patient is stabilized, we have to start at low doses, and then slowly we have to increase the dosages on OPD basis. Okay. So this is called GDMT, goal directed, guideline directed medical therapy. So suppose if everything goes fine, 90% of the cases, this is the thing we follow. But sometimes instead of giving keeping on ventilator or inotrope, the patient may not improve. So that is the where we use mechanical circulatory support systems like IABP, ECMO, and Impella. Just you should know something about these things. So these are the supportive systems. So this is mechanical circulatory support system. So these things supports mechanically the left ventricle or right ventricle, which is weak. Right? So most common thing we use is IABP. And support system wise, IABP, it increases cardiac output up to 1 liter. And then Impella, nowadays we are using Impella in our hospital. So it can increase up to 3 liters or even 5 liters also. It can increase the cardiac output. And then ECMO, so this can increase up to 7 liters. These are the 3 modalities usually used in short-term support. In the long term, there are other mechanical circulatory support systems called artificial heart and those things. Okay, HeartMate and those things. But these things are used in short term in emergency. What is IABP? Intra-aortic balloon pump, counter pulsation. So this is a pump. This is the balloon. This will keep in between left subclavian artery and then renal artery. These 2 things are important, right? If you keep it above, so it will impede the blood circulation to the left upper limb, it causes ischemia. And if you keep below the renal artery, and again it causes renal dysfunction. That's why we'll keep in between. What it does, it is connected to the helium pump, and then it will pump. It's a counter pulsation. That means it pulsates opposite to your cardiac pumping. That means during systole, it is deflated, right? And then during diastole, it is inflated. So once inflated, so then during diastole, these coronary arteries, heart, and then brain and these upper limb vessels, the blood pressure will increase. Diastolic blood pressure above this one will increase. So that increases coronary blood circulation. If the patient is having heart failure because of coronary ischemia, it improves the coronary blood flow, right? So, and then after inflation, sudden deflation during diastole. So this helps in reducing the resistance. So heart can pump towards a low pressure system. Okay. So it helps in 2 ways. One thing is increasing the coronary blood circulation by inflating during diastole. And then during systole, it will deflate. Sudden deflation causes low pressure system. Heart can pump easily. There is a low pressure, low resistance system. So this is IABP. Okay. And then what you are expected when the patient is on IABP? One thing, you have to see the left radial pulse. Sometimes it may migrate above left subclavian. How can you see? So whether the balloon migrated above or below. So then If it is above means if the left radial pulse is you are unable to feel, that means that migrated. The placement is not correct. The balloon is above the subclavian. And then you have to see the renal function, urine output also. If urine output is not there, and then that indicates that probably that balloon is migrated below. That is the one thing. The second thing is pulse you have to see, lower limb pulses. So because it's a very big balloon, and then that causes some stagnation. Whenever stagnation in the aorta, so that causes blood clot formation. So sometimes it may cause thrombus formation. And that too, it's a very big bore. Usually if the iliac artery, that artery is narrowed, it may cause gangrene or ischemia of the limb. So for that reason, always you have to feel the temperature, whether it's both legs are of same temperature or not. If that limb is cold means think that is getting compromised. Okay, and also feel the pulse, and then you have to take care of anticoagulation. You have to check uh, APTT, and you have to give a heparin flushes, and then usually we get continuous heparin infusion. But you have to check a APTT at least 6 hourly, and then you have to inspect the puncture site. Many other times, usually that bone may cause some puncture site, hematoma, or some sepsis. So these are the things you have to see in IBP. And if you are skilled enough, even you can see the monitor, whether it is giving working properly or not. So this form usually we'll see in the IABP monitor. Okay, and then usually we'll set a number 1:1, 1:2, 1:3. That means one pulsation with for 1:1 means each heartbeat it's giving one, and 1:2, 1:3 support. So usually in initial phases we'll give 1:1, and then once the patient is stable, and then weaning off, then we'll make it 1:2, 1:3, and then we'll wean off. That also you can see. But these things are minimum for you. And then impella. So what is an impella? Impella, it's a catheter. So this tip is in the left ventricle or right ventricle, depending upon the tailed ventricle. And then this portion has a pump, rotatory pump. Okay. And then this is connected to the console. It directly pumps blood from the left ventricle to aorta. Just you can see if it runs. See, there is an inlet here. It is taking blood from this part, and this is the outlet. So this is coming out. Okay. So it just pumps the blood from the left ventricle to the aorta, or if it is the right side, right ventricle to the PA. So that by that, so it relieves the heart, and it gives some time to do the procedure. Usually we'll use this for protected PCI. That means during patient is in cardiogenic shock and patient had a M or something, and then we want to do a piece angioplasty, but patient may or may not tolerate. Very procedural support we'll use, even if this can be used for even other cardiogenic shock for a short-term support. Okay, so this is the impella. If the patient is on impella, the same thing, just like IABP, we use the femoral artery, and here also you have to check for the groin inspection, and then lower limb pulses we have to see, and see for the anticoagulation. But one more thing we have to be careful is hemolysis. So because it's a pump, it has a screw kind of mechanism. Its screw rotates. This is called Archimedes screw. So in that pump there is a screw. Screw rotates. That's why it draws blood from the left ventricle into the aorta. So during that time, sometimes there is some damage to the RBCs. So it may cause hemolysis. So then that hemolysis is one of the complications with the impella. So for that you need to see. That means hemoglobin we have to see. There is a fall in hemoglobin, and then hemoglobin, once there is a hemolysis, there is a hemoglobinuria or hemosideruria. So that the patient will pass uh, bloody urine or dark colored urine, and it causes renal dysfunction. Patient may end up in ARF. So this is the one special precaution to be taken if the patient is on Impella. Okay. And then this you have seen ECMO. During COVID days, many patients were on ECMO. Okay. This is especially patient has a heart failure as well as a pulmonary. So both lung and heart are at problem. And then both oxygen levels are low as well as the BP is low. This support we will use. So because it supports both respiratory system as well as the cardiovascular system. So here there is a pump. So we draw blood from the venous, that is usually femoral vein, and again it ejects into the again artery, femoral iliac artery. Okay, and then in between there is a oxygenator. So the deoxygenated blood is taken, and then it's actively pumped. So because pump relieves the heart, and then oxygenator, it takes care of that oxygenation of the blood, right? So this is most effective and usually used in very sick patients of heart failure. And if the patient is on ECMO, one thing we have to see is there is no pulsation kind of thing here. It's a continuous pump. So that's why we have to see regularly. Usually pulses will be, you can't feel much pulse. It's a feeble pulse. Okay, because there is no pulsatility. Okay. And then you don't look at the systolic blood pressure and diastolic blood pressure because it's not a pulsatile, no? So that's why you have to mean map. So here the monitoring you should do is map, right? So map should be at least 65 mmHg. And then second thing is, again, look for the urine output and then kidney function, right? And saturation levels, that is if ABJ, if you are doing, always take from the right hand, not from the left hand, right? So in this case, so because there is a fallacy called north-south syndrome. Let me explain. The patient had both lung function is compromised, hypoxia, and then basically patient is having multi-organ dysfunction syndrome, and his heart is also weak. So usually we are draining the blood from the vein, and then we are oxygenating and then pumping back. So from this, it goes back, and then aorta, all because heart is weak, usually the flow will be in reverse direction. Okay, so from iliac leg to the aorta to the upper limbs. So that's why all the saturations will be equal. But once heart is little improved, but lung still not improved. So usually this blood flow will go up to this point, but because heart already improved, it also tries forward also. So this pump cannot negate and the push blood up to the upper limbs. So from this portion, the ECMO blood flow go through the ECMO, and then upper limbs, because already heart is recovered. So then these upper limbs, there is a right up, especially right arm and then head, they'll receive from heart only, which is deoxygenated. So there is no oxygenator there. So that's why sometimes you may find so better oxygen saturations in left upper limb, and then low oxygenation saturations in right upper limb, right and left. So that's why it's if patient is an ECMO, it's better to take a saturations in right upper limb. Okay, before taking off ECMO, you may think that the oxygenation is better, so but that is because this lower limb and as well as left upper limb, they are getting blood circulation from pump. The pump is this ECMO is pumping retrogradely, so into aorta, so that is going up to the left subclavian, and then because heart is recovered and it's pumping forward also. Previously it was not functioning, that's why completely dependent on ECMO. Once little heart is improved, so then this right upper limb and then brain may get blood circulation from that routine forward flow. Okay. So then once this is done, this is acute heart failure. So then patient somehow may require mechanical circulatory system or ionotropes, then patient is fine, now decongested. So then what to do? So then we have to initiate protein drugs, so which improve quality of life and survival. So here, what are the drugs used in heart failure? These things will initiate, and you have to see that whether all the patients are receiving these medications by the time of discharge. Acute part is over, then our is aim to then reduce the readmission rate as well as to prolong his survival. Okay, you should have a good quality of life after discharge, and then you should not come back to us with again for readmission. These medications are compulsory. So one thing is ACE inhibitors and ARBs. ACE inhibitors, angiotensin converting enzyme inhibitors, that is ramipril, enalapril, and then ARBs, angiotensin receptor blockers, valsartan, telmisartan, and olmesartan. These things, they have to be all the patients with a heart failure, with the reduced ejection fraction, they have to take. These are for heart failure with reduced ejection fraction. Heart failure with preserved ejection fraction, till now, this is not an indication, but now there are trials where Vimada can be given. Okay, so these patients, before giving, you have to check whether the blood pressure is okay or not, right? If the blood pressure is more than 100, then you can give. And then after giving these ACE inhibitors and ARBs, you have to check the blood pressure. ACE inhibitors especially, they cause orthostatic hypotension. At least one time in hospital, you have to check a blood pressure in a standing position. What is orthostatic hypotension definition? What do you mean by orthostatic hypotension, and what is the definition criteria? So blood pressure in standing position, if the systolic falls by more than 20 and then diastolic falls by more than 10 mm compared to the sitting or supine blood pressure, so then that is a cutoff for to define as a orthostatic hypotension. If the blood pressure is systolic blood pressure is falling by more than 20 millimeters, and then if the diastolic is falling uh, more than 10, so then the patient is having orthostatic hypotension. Then either that is because of the dehydration, that means you are giving more diuretics, so you have to reduce the diuretics, or else because of these drugs. So then you have to reduce the dosage of these things. Okay, and then you have to see for the renal parameters also, right? And then Arni, that is sacubital valsartan. So most of the patients nowadays we are giving Vimada or Sidmas or Asmada. Then this medication you should be aware. It's a combination of valsartan as well as sacubitril. Sacubitril is a neprilysin inhibitor. It increases the diuresis. And then beta blockers. Beta blockers should be given in all patients with heart failure if there is no hypotension and if there is no bradycardia. If the patient is having bradycardia, no beta blocker. If the patient is having heart failure with still the pedal edema and SOB is there, then you should not give. The lungs should be dry, and then hypotension you should not give. And the patient is having COPD, then you should be careful. So most of the beta blockers now they are cardioselective, so no, we can give it. Okay, so and then after starting a beta blocker, we have to carefully monitor the heart rate and blood pressure. Some beta blockers they will cause bradycardia and those things, so we have to check for these things. Because beta blockers, they have multiple advantages. Even they reduces the chance of VT and VF also. Okay, and then aldosterone, mineralocorticoid receptor blockers, spironolactone and eplerenone. This is also a must. All the patients who are getting discharged, they have to get it. So you see that beta blocker, either ACE inhibitor, ARB, or Vimada, any one of these. We won't give three, only one of these things. All are acting on RAS system. And then mineralocorticoid blockers. These three things should be there in a treatment chart unless there is a contraindication. If there is a kidney injury, a CKD, usually we won't give ACE inhibitors. And if there is a bradycardia and those things, we won't give beta blockers. And then these things, unless there is a contraindication, these things we have to give. So then when to shift to what? One thing is patient's symptoms improved and the heart rate should be less than 100, resting heart rate. And then there is no orthostatic hypotension checked in ICCU. And then urine output is good. And then saturation is more than 95% on room air. And kidney function is stable. The patient may not have a normal kidney function. If the patient is already having CKD, at least the patient parameter should be stable. If these are things are there, then you can shift to what? And then when to discharge. So discharge criteria are completely decongested, and then whatever the precipitant, if the patient had an infection prior to that, it has to be controlled. If it is because of arrhythmia, it has to be controlled. If the patient is having angina, it has to be some angio and angioplasty was done. So the precipitating factors was addressed or not, and then comorbidities are controlled. Suppose the patient is having hypertension, diabetes, and those things have to be controlled before discharge. And then at least 24 hours, a patient is on oral medication. So oral diuretics of inotropes. And then patient has received these beta blockers, ACE inhibitors, and those things at least for 1 day. So if these criteria are met, then only patient has to be discharged. Otherwise, if this is not met, the chance of again readmission is very, very high. So these things you have to check. So then these are the things, discharge criteria with heart failure. And then what next to be done? So you can check it. See, this you can have it, and then the patient is having ACE inhibitors or not. If no, what is the reason? Why he was not receiving? And the patient is taking beta blockers or not? And these medications, and then even you have to mention ejection fraction. The discharge summary, it should have what is the EF at the time of discharge and what is the patient's weight at the time of discharge. So this for follow-up, it will be easy. And then many patients, if the patient is having AF and severe dysfunction, we will give oral anticoagulants. So because if the patient is heart failure, they'll have a LV clot formation leading to the CVA, cardioembolic stroke. They are high risk of cardioembolic stroke. That's why patient, whether he is receiving oral anticoagulants or not. And then even you have to do a counseling, not only medical therapy, the role of cardiac rehabilitation. So it's more and more in especially in heart failure patients. That is the reason why one topic of cardiac rehabilitation regarding exercise training as well as diet we have included in this thing. So because there is a lot of role of cardiac rehabilitation, and those things you should be aware, and you should stress upon at the time of discharge. So we have a heart failure coordinator by name Saumya. So if all the patients with heart failure, just you can inform her so that she will do some counseling. Okay. And then we'll give a booklet. So we have a heart failure, how to live with a heart failure booklet, educational material that all the patients should get it so that they can go through. And then at the same time, we have to advise some tips to be monitored, to be followed at home. Self-care education should be done. So because most of the times they will again come with the pulmonary edema and those things. How to identify early symptoms, and then so that they can call us. Okay. So to improve the quality of life, we have to educate the people, and then the patient should get low salt diet, and then fluid restriction. It is advised by a doctor as a nephrologist as well as a cardiologist, depending upon patient to patient basis. And then they have to monitor weight daily in the morning. So if there is a increase in the body weight of 2 kgs within a 1 week, that is the early warning sign. So that means again there is a fluid deposition. Okay, around weight gain of around 700 grams to 800 grams per day, or within 1 week 2 kgs. It's a difficult to say day to day because there is a lot of errors. So especially if the patient is gaining 2 kg weight after discharge uh, within 1 week, that means the diuretic again he is developing fluid overload. There is a fluid deposition. If he comes at that point, we can again increase the diuretic dose, and then we can reduce the chance of readmission. This is we have to stress upon. They should have a weighing machine and they have to take care of that. And even we'll give them chart also at the time of discharge so that so they have to what things they have to maintain, like weight. If they have a pulse oximeter, they can have a pulse rate and this thing saturation also. And then if the patient has any symptomatic worsening, so then what they have to do? Usually we'll give you our heart failure coordinating number. At least they can call us so that we can adjust. If the pressures are okay and saturation is okay and everything is okay, just by adjusting the dose of diuretic, they can no need to come to hospital, especially from remote places. And then you have to explain about the medications, right? And then you have to uh, advise them regarding tobacco, smoking cessation, and alcohol. So most of the time, the heart failure patients, alcohol no. So coronary artery disease, usually we may advise moderate intake of alcohol consumption, but patients with LV dysfunction, heart failure, the alcohol, even moderate amount also is absolutely no. And even they should take care of nutrition. That the patient who have we are ill nourished, they succumb more. So the patients with overweight patient, they may better tolerate the heart failure than the patient who are ill built. So because there is less protein. Okay. So that's why usually they should maintain a good protein. The weight reduction in the weight doesn't mean that overall weight. They have to gain muscle weight and they have to lose the excess weight because of water. Okay. And then always, if the patient has lost weight, that is also bad. That's why we'll take a nutritionist help, and they have to build up muscle mass so that they can tolerate the heart failure better. And then, so these are the things you have to take care at the time of discharge. So one thing, our goals in treatment of heart failure is, one thing is improving survival in acute care as well as in chronic heart failure by advising the medication. And then we have to reduce the chance of hospitalization. This thing we can do by a heart failure team where you are a part of the team, and then coordinator and other treating doctors and rehabilitation. This team is a heart failure team. So by working as a team and by better coordination, we can reduce the readmission rates, which is almost 50%. 50% of the patient, they will again readmit. And then you can increase the functional capacity. So the most of the patients with heart failure, we won't advise any exercises. So, but not only increasing his life expectancy, we have to give better, he should have a better quality of life also. So then by involving a physiotherapist and dietitian here, we can increase, we can make them encouraged to do more activities, and then should reduce the symptoms. Ultimately, we have to improve the quality of life. So these things, usually educational material we will give with the patient. Okay. And this is the overall management of heart failure. This is acute decompensated stage where inotropes and oxygenation, those things are taken care of, and then gradual introduction of the medicines, and then even after post discharge also. So you have to take care of other things. So the heart failure team it constitutes treating doctors, cardiologists, intensivists, surgeons, nephrologists, but the most important role be played by nurse. So our goal, ultimate goal will be to optimize the medical therapy and the cardiac rehab, and then to improve the quality of life as well as his life expectancy, right? So actually, because of some issue. Dr. Sridhar got stuck up in case, so that's why I extended the whole heart failure treatment, not only in the ICCU, so even what to be done, what medications to be given for heart failure in chronic heart failure also. So this is the overall thing, but you will be having lot of doubts, I think. So now you can ask questions.
Questions again open to the podium, and YouTube viewers, you can pose your questions in the link which we have given. Here, your questions are taken up. Dr. Nitin is ready to answer your questions. Offline viewers and online viewers and the podium team, anybody can ask questions. It was so well, enlighten all the points. Really, sir, you have put a lot of effort. Nursing perspective, I think my nurses are well benefited with this PPT, and very, sir, very informative, I can say. Even as a cardiac nurse, 10 years taken me back away, sir. As I worked as a cardiac nurse, critical care nurse, I've seen many dilated cardiomyopathy patients with heart failure and patient with dobutamine, stress echo, and fallen with esophageal hypotension, either cardiac dysarrhythmias. We have seen many cardiac events occurred in during treadmill with dobutamine stress echo, leads to heart failure. And certain patients, sir, I have one question, sir, can I ask? Especially when patients, one of my cousin at the age of 32 years, he undergone for implantable cardiac defibrillator. If you give recurrent shocks, maybe myocardial damage occurs, or and it may lead into heart failure and sudden emergency. He brought up ER around 3:30, and Dr. Narasimhan was cardiac intervention, and entirely the ICD was blocked, and so much of problem he faced, and he was in 1 week ventilator, and he recovered later. But sir, is it major complications, especially as you said, the cardiac rehab? Such kind of patients at the early age group, and he is not having any such kind of bad habits. He's non-smoker, non-alcoholic, non-diabetic, but still he has, has myocardial damage after implantation of cardiac defibrillator. And as a nurse, what kind of precautions as a family member, either, patient family education, as you said, those days, 90s cardiac rehab is not that so aggressive. So now also there are patients landed up with heart failure, severe damage of intracardiac defibrillator. Can you suggest some tips for the nursing perspective, either as a family member, how we have to take care of them, and what kind of suggestions you can feel, like from point of ours, you can tell us. Any other questions also, you feel free to ask.
See, heart failure is because of many things. So primary cardiac muscle issue, that is a cardiomyopathy. So cardiomyopathy, most common cardiomyopathy is dilated cardiomyopathy. It's where the cause is unknown. It's idiopathic. So it's because of some abnormality with the cardiac myocytes. So there are some are inheritary, some are spontaneous, some abnormalities, genetic and other things. So that leads to the fibrosis of the cardiac muscle or myocyte. That leads to thinning and then their cardiomyopathy. So there is no permanent cure actually. But only thing is with medications we can slow down the uh, worsening of the heart failure to some extent. And then, so as the muscle stretches and then the scarring of the cardiac muscle, it's prone for arrhythmias. So the patient presents with VT and VF. So VT and VF are most malignant forms of arrhythmias. So there, when the patient has a heart failure and then arrhythmia, so then that is an, especially VT, ventricular arrhythmia, that is an indication for ICD, so intracardiac cardioverter defibrillator. So there, so first is the indication. So all the patients with heart failure with a VT and VF episode, it's a class 1 indication. We have to put ICD. But the thing is, they have to be monitored properly. So because, see, if you see ICD, so this what ICD does is, first it will detect, it will monitor the rhythm. So first it will detect whether it's beating normally or not. And then whenever, see, there are three parts. One thing is sensing. So it's a normal sinus rhythm, fine. And then once it detects some abnormal rhythm. So this is programmed. So if this type of pattern is there, so it has to give a shock. So then there are multiple morphologies are programmed into it. So if the rhythm, it fits into that kind of abnormal pattern, it immediately delivers a shock. So one thing is, it has three functions. One thing only sensing, is a normal or VTVF. Second thing is pacing. So if it is a heart rate is low, it works as a pacemaker also. And third thing is, whenever there is a VT and VF, it will gives a shock. But which will usually, it will be very, very less, only 1 or 2 joules, not like 100 joules what we'll give in external cardioverter. So, but the thing is, to avoid inappropriate shock, we have to frequently program it. So every 3 months or 6 months, we'll program it, and we'll evaluate last 3 to 6 months how many abnormal rhythms were noted, whether it could pick up or not. And sometimes it may not pick up, that is a danger. So sometimes patient may have VTVF and it is not function. And sometimes it may pick up some vibrations or some other rhythms as a VTVF, and it may give inadvertent shocks, inappropriate shocks. That will be discomfort for the patient. Suddenly she will feel something. So for that thing, frequent monitoring, and then frequently we have to program that ICD. But the thing is, ICD, it will prevent these sudden cardiac arrest episodes in case patients with heart failure.
Even the environment factors will contribute to make heart damage, right? No, so even the patient was like, usually the doctors advise to be in a light, cool, calm environment. Workplace should be there, and sounds. Is it required to educate for the patients, such kind of patients, if elderly aged group, if they have placed ICD or permanent pacemakers, the sound pollution machinery, that any such kind of advices we have to guide for them, sir?
No, no, there is no proof like that. But in a heart failure patient, one thing is
They should not be excited, and
uh,
exercises, everything will be limited. Even for attending big parties or some kind of sound pollution cannot be advised, they suggest. Is it true?
no, all pacemakers only precaution is that the electronic checkpoints will be there, no airways and airports and those things. So that security, that thing you should not go, because there is some electromagnetic impaction will be there, impact will be there. Otherwise, stress as such, it won't impact much. But in any heart patients, so stress causes sympathetic stimulation that adversely affects both coronary artery disease as well as the heart failure. So we have to uh, some adopt stress relaxation in those things. Always advisable.
Meditation, music, diversional therapy that you suggest my nurses. So usually patient family education, they always, as you said, discharge note. Nursing is the first primary goal where they have to put their efforts while discharging the patient. As a stakeholders, you need to educate patients, as suggested that leaflet, some booklets or some guidebook, we have to take responsibility and accountability to educate for the patient and patient family. Any other questions? Rajesh and team, I should not pick up only Rajesh. ER team, critical care team, do you have any other questions?
No questions. I need to ask questions.
So there will be hemolysis, and there will be
Chance of hemolysis.
chances. So if there is a chance, let's assume there is a hemolysis in the titration of the screw. So rapidly, how much can the hemoglobin can come down?
If there is any drop by more than 2 grams, it should be suspicious.
So there will be any impact on like increasing the bilirubin levels.
Definitely. Hemolysis causes everything. Hemolysis causes indirect bilirubin elevation, LDH levels will be elevated, and then urinary urobilinogen will be elevated. And those things, they are all the wherever the hemolysis happens, the same.
So in these procedures now, any blood transfusions are done immediately or slowly, sir, post or after procedure?
So if you are facing a hemolysis, usually it won't be that much severe enough. Okay. So that, but if patient has a severe hemolysis, then we need to try to wean off that impella.
Without asking any questions. I think all my nurses are benefited with this topic. Everything he covered, even drugs and cardiac intervention management, okay, as well as discharge therapy. So any more questions from audience, please post in YouTube viewers, whoever in audience, because this link is Zoom link only for permitted doctors. YouTube viewers, you can post questions, even break time, sir will answer. Either we will answer you personally also, whoever, whichever you need, inside the hospital, outside the hospital. Okay. YouTube viewers, you can pose your questions. I think right now I have seen there is no question for sir. If you have further also, you feel free to pose your questions. We are ready to answer your questions. Podium, anybody? If you don't have, sir wanted to ask some questions. Is it okay for you?
So this basically just I wanted to cover basics of heart failure once the patient is admitted from ICU to discharge. But the next thing will be, so the patient who got repeated admissions. Okay, so then that is called advanced heart failure. Advanced heart failure means the patient is requiring at least the more than one hospitalizations for heart failure in 1 year, and then patients requiring high dose of inotropes, we are unable to wean off. And then the patients with heart failure with a worsening other organs function. The patient previously only heart failure, but now renal function, other functions also deteriorating because of heart failure. And then patients with they're requiring high dose of diuretics, and then they are not tolerating. So the patient is symptomatic. If you increase the diuretic, they are going to hypertension. Otherwise, they are developing dyspnea. So then those cases are called advanced heart failure, especially EF with below 25%. They are called advanced heart failure. These cases we have to pick up. So because the next feature will be regarding interventions in advanced heart failure. So where we can offer something like a LV assist devices. So there is a mechanical support, so where they can just it's surgically implanted. So but it's a alternative to transplant. Actually, advanced heart failure transplant is the gold standard. That is a main therapy, but it's difficult because of logistical issues. Okay, so and then immunosuppression and those things, and then availability of donors, and patient may not accept it. But there are other artificial or mechanical circulatory supports are available. So those things I didn't cover. So but we are trying to start this program, heart failure clinics, so that with the aim to detect these advanced heart failure patients, so that we can enroll in a heart transplant as well as the mechanical circulatory devices implantation. Okay, so for this also, first we have to treat the initial episode properly, and then we have to evaluate the reversible causes, like if arrhythmia, then it has to be addressed. Any coronary artery disease, it has to be addressed by revascularization, and then usually we'll treat for 3 to 6 months, and then instead of giving excluding all the reversible causes, and instead of giving all these guideline based medications according to dosages, if the patient is not improving, then we are enrolling in advanced heart failure, and then we are monitoring them. So you coordinate with Soumya. She is a heart failure coordinator, and she will take care of those patients. If they are eligible and okay with that, we'll advise advanced heart failure supports. If the patient is not eligible for that, at least we can give a palliative care. We can give a better quality of life. We may not extend his life, but at least we can give better quality of life by adjusting the medication, as well as giving some dietary counseling, and giving some exercise training and those things. Okay. Right.
One question from YouTube viewer Ramesh Shutukuri. Can you know more about orthostatic hypotension?
Orthostatic hypotension uh, means usually uh, blood pressure will be more in supine position. Okay, systolic and diastolic blood pressure, but as you stand, so then usually the blood pressure will come down, but okay, because of that hydrostatic force, okay, and then there is a pooling up of blood in the legs, but immediately once the vascular tone is good, again it will react and it will be compensated. Usually the blood pressure fall will be less than 20 in systole and less than 10 in diastole, mean of less than 15. Okay. So then, but in patients with some fact reasons, like one thing is excess diuresis, hypovolemia, and second thing is uh, any autonomic neuropathy. Like diabetic patients, they will have a sympathetic nerve, that autonomic neuropathy. So where, so they can't. So usually once you get up, so there will be little fall, but again it will be compensated because of the uh, arterial constriction. That is because of sympathetic nerve system. So if there is autonomic neuropathy, then also there will be fall, and that is one thing, especially in diabetic patients and some reasons with autonomic neuropathy. And third thing is because of ACE inhibitors and ARBs. So they also cause orthostatic hypotension. So that's why the patients with heart failure, always you have to check for orthostatic hypotension in hospital before discharge at least once, right? So if the patient's not receiving diuretic, no ACE inhibitors, and then he is euvolemic, so then you have to evaluate for other autonomic neuropathy. But in heart failure, most common reason being the excess diuresis and the excess nitroglycerin and those things and beta blockers ACE inhibitors. There, will first he'll reduce the dose of diuretic, and then he'll reduce the dose of or stop the ACE inhibitor for some time. So you can continue beta blockers and those. And even you can advise also in all heart failure patients, uh, before getting up from the bed, let them sit for some time, then let them stand for 1 to 2 minutes, and then move. So many patients, they'll collapse in the bathroom in the midnight, they'll get up from the sleep, deep sleep, and then they'll go to bathroom and there they'll collapse. So this is mostly because of orthostatic hypotension. The movement is happening rapidly. So most of the midnight bathroom collapse is because of orthostatic hypotension. Ah. So the main thing is weight. So intake output chart. So for which catheterization is not mandatory. You can educate the people, let them collect in that thing, and you can take that. And then weight monitoring is compulsory. These two things should be focused in wards.
Thank you so much, sir. I think no more questions. That is the reason I'm just, I mean, your slide is very well explains everything. That is pathophysiology, this is interventions and management, everything very beautifully you put into nutshell and you have given us. That is what I am considering. I think my most of the nurses was also will agree with me, right? It was so self-explanatory by, yes. Any small questions also triggering on your mind, please feel free to day you're working on bedside, you have seen many patients, landed with cardiac arrest, especially early morning EMWS. Always I trigger that and landed up activated code blues. You have seen, or if not break session, you can feel personally to talk to sir and clarify your doubts. If you have stage fear on podium, if you're not able to question, you can even feel free to pose your questions on YouTube without your name anonymously. We are here to answer. Thank you so much, sir. If any questions comes, I personally message you, sir, from your point of view. Yeah. Now, without taking much time, I know since morning you are not requesting for tea break, but we have short of span. Lunch is arranged, so there is no tea break. We will continue with the next speaker. Now, I would like to call upon Miss Srilata, okay, our HOD dietetics, working with us, madam, in last 7 years in medical hospitals. Ma'am has completed her MSc Nutrition and Dietetics, and she is a registered dietitian from NEN company. And ma'am has overall 18 years of experience, and she is a regular speaker for Arogya Setu program in ETV Live. And she has done many case presentations and poster presentations, national and international conferences. And she's the best speaker award got from Jeevana Rekha in ETV Live. And ma'am was given various TV shows in YouTube channels. Ma'am was renowned speakers in Telugu TV channels, and she was debates in Telugu news channels like TV9 and Maha News. And ma'am was having anonymous knowledge on nutrition therapy, provided articles for various newspapers in nationally and internationally. And she has held talks about guest lectures for various NGOs and corporates and colleges and schools. So without taking much time, I would like to invite Ms. Srilata ma'am to take the podium and make our nurses to useful of your session. Role of cardiac rehabilitation in the heart failure and nutrition therapy. Thank you.
Thank you, Swati.
Ma'am. Okay, small information. There is a feedback form given to you. Just circulate in yourself and give the by end of the program.
Good morning, everybody. I hope it's afternoon. Yeah. So I'm forced to speak very quickly. I'm going to do that. So I'm going to talk about the nutritional management in heart failure. Since morning, we had excellent presentations by the speakers. So the symptoms have been already discussed, but I just wanted to show you all that these are the basic problems they will be facing, with which they will be having certain amount of decrease in the energy stores. Okay, they will be malnourished because of the polypharmacy, because of the ongoing symptoms. So what happens exactly? So the heart cannot process sufficient fatty acid or glucose to maintain the adequate supply of energy. There is reduced ability to synthesize the ATP, which is leading to impaired contractile function, failing heart being energy starved, and it is referred as an engine out of fuel. So adequate nutrition for sufficient ATP production may be important in improving the failing heart's function. Now, what are the goals and objectives of management? So we need to understand that we have to reduce the cardiac workload, reduce the breathlessness, to lower the edema of the body, and also to assist the drug therapy and also managing the cardiac cachexia. So nutritional intervention becomes difficult as the heart failure progresses, and we need to try to prevent the unintentional weight loss in the advanced diseases. So what is the dietary intervention going to do? So if you have a regular follow up, and adequate nutrition therapy is given with a very good dietary description, then definitely the overall nutritional status is improved, the quality of life is improved, the reduced severity of the symptoms. You can just find that the symptoms keep on lowering, and the frequency of coming to the hospital was administration, I mean, hospitalization is also reduced. So there are multiple dietary strategies and approaches available, but there are supposed to be two well-known diet approaches. These are nothing but your famous Mediterranean diet and DASH diets. So these are cardioprotective diets. So Mediterranean diet suggests that inclusion of your green leafy vegetables, different types of fruits. It focuses more on healthy fats. Your total amount of calories should at least have 35% of fat, and it should have minimum of 27 to 30 grams of fiber. This is the gold rule for the Mediterranean diet. And DASH diet includes high consumption of fruits, vegetables, nuts, legumes, whole grains, and fish. So whole grams can be your cereals, your millets, pulses, dals, everything. So this type of a DASH diet provides a synergistic effect of different foods. It is not focusing on a single nutrient. All we need to understand is you cannot run behind energy or protein or fat. It should be a multiple nutrient approach. It provides healthy carbohydrates. Carbohydrates plays an important role. So in my further slides, I will be discussing about. So we need to choose healthy carbohydrates that is being provided by DASH diet. It is a source of protein, MUFA, PUFA, omega-3 fatty acid, good amounts of potassium, magnesium, calcium, vitamins, antioxidants, and fiber. These DASH diets are excellent in potassium. That's how your blood pressures are under control. They have good amounts of fiber. So fiber again keeps the sugars, body weight under control. So again, your blood pressures are maintained with that. So basically, they are very low in sodium, saturated fat, and cholesterol even. So now, what is the medical nutrition therapy? So dietary modification depends upon the edema present, depending upon the shortness of breath and the existing comorbids. So if the person is obese or if the person is underweight or severely cachexic with the cardiac cachexia, you have different management guidelines. You cannot have a blanket fold statement. So overall nutritional status is important. So ideally, we need to give them small, frequent meals and to reduce the workload of the heart, and we have to meet the full requirements. The consistency may vary from normal to soft depending upon the ability of the patient to consume. So patients who are on high potassium, like loop diuretics or potassium wasting diuretics, you should be very careful in administering the potassium because it's a very important mineral. We cannot see hypokalemia. So basically, millets and cereals are excellent source of energy. They also provide proteins. They give you vitamins, minerals, and fiber, especially B complex vitamins, your thiamine, riboflavin, the pyridoxine are there in the cereals and millets. So the energy requirement for heart failure patients should be given, to maintain the basal requirement, and additional 20 to 30% of energy will be in the demand. So depending upon the catabolic state, the energy is adjusted. So legumes are excellent source of protein. If you take 100 grams of legumes, they give you around 23 to 28 grams of protein. And they also give good amounts of calories, let's say around 325 kilocalories of energy. They are again good source of fiber if you're consuming them as whole grams. And if you're adding large amounts of greens and vegetables to dal preparations. So protein in a stable heart failure patients, you will be requiring 1.1 grams of protein. How much of protein do we need normal people? 0. 0.8 to 1 gram. So they will be needing 0.1 gram additional. Well nourished patients, okay? So if they are undernourished, you can go up to 1.4. If they are hospitalized on supports and catabolic, then it can go up to 2 grams even if they are hospitalized for a long period of time. So you have to preserve the body composition, and you have to limit the effect of hypercatabolism. Fruits and vegetables are rich source of potassium, magnesium, and iron. They are excellent source of folate, B9 vitamin, which improves the anemia. Then it provides antioxidants and fiber. And there are many studies which have proven that if you're taking more than 5 servings of vegetables, there are beneficial effects in heart failure patients rather than taking fruits. Whenever the patient is sick, they feel that I will start eating a fruit, an apple or an orange, something like that. Fine. So vegetable are supposed to be having good amounts of nutrition when compared to fruits because these days fruits are genetically modified. So low fat milk and milk products are ideal for consumption. They're excellent source of high biological value protein and calcium even. They're good source of vitamin A and riboflavin. Yogurt is a very good source of probiotic. It improves the intestinal microbiota and it improves the gut health and overall immune system. But we need to understand that we cannot depend upon the sugar coated or the highly processed yogurts. Nuts and oil seeds are excellent source of monounsaturated fatty acids and omega-3 fatty acids. They're rich in magnesium. Magnesium is an important electrolyte for cardiac activity. Again, calcium, zinc, and iron. So these are the minerals you get from nuts and oil seeds. They're excellent source of energy even. If you take 100 grams of any of these nuts, they give you 500 plus kilocalories of energy. Let's say peanuts gives you 525 calories, almonds gives you 530, walnuts gives you 630 kilocalories of energy. They're again excellent source of protein. Like peanuts gives you 25 grams of protein, almonds around 14 grams of protein, till is again 18 grams of protein. And we need to understand that till and almonds are excellent source of insoluble and soluble fiber. So these nuts will improve your good cholesterol HDL and will lower your LDL bad cholesterol. So cooking oils, we have different varieties of cooking oils available. So depending upon the body composition of the patient as BMI, we have to limit the oil. It can be from 4 to 6 spoons or 3 teaspoons, even if it's very obese, morbidly obese. So rotation of oil is recommended. Do not blend the oils, do not mix them because no oil is rich in all the fatty acids. We need monounsaturated fatty acids, which is a cardiac friendly fatty acid that is present in your olive oil. And for economical population who cannot afford olive oil, peanut oil or groundnut oil is an excellent source of monounsaturated fatty acids. If you take long usage or people are getting carried away with sunflower oil, but it is having a lot of PUFA, polyunsaturated fatty acid. So it is a pro-inflammatory. You cannot depend upon only one oil. Fine, you need to change your oils. Mustard oil again is rich in MUFA. So sesame oil is our old oil. You should never neglect that. It has a good balance of MUFA, PUFA. It has multiple what do you call fat soluble vitamins and antioxidants. But whichever oil you want to use, you should limit according to the condition. Non-veg again is an excellent source of omega-3 fatty acid, especially fish. The rich source of protein, high biological value protein. You get good amounts of trace elements, vitamins, and minerals. So this can be consumed in moderation. You cannot do excess again. Skinless poultry, at least 75 grams 2 times a week is okay. Alternate days, eggs can be given for the patients because they are a good source of multiple vitamins. You name them, that is present except vitamin C. You need to understand it also gives you 215 milligrams of cholesterol in one yolk, but it is all individualized. Patients with a risk of family history or having hyperlipidemia can take around 2 to 3 yolks per week. And do not prepare omelets, fries, or burgis. It is always ideal to boil and consume them for their better absorption. Red meat is very high in cholesterol, high in sodium, high in saturated fatty acid, and the risk for heart failure increases with the higher amounts of red meat intake with or without previous MI. Excess salt increases blood pressure, increases edema, damages the arteries, increases the risk for heart diseases. It shortens the time to transplantation in patients with advanced heart failure. So it is ideal to always limit salt in HF patients. Sodium restriction has been a significant nutritional recommendation for the reduction of congestive symptoms. It lowers the edema, prevents the fluid overload. Stringent low salt intakes around 1500 milligrams for A and B stage patients of CHF only. The Heart Failure Society of America recommends less than 2000 milligrams per day, even up to 1000 milligrams, depending upon the left ventricle dysfunction, depending upon the pulmonary edema, depending upon the overload of the fluid status. We can go up to 1000 milligrams per day, but in very rare cases. Seasoning with herbs, spices, herb vinegar, and fruit juices, it mimics salt. It will not demand for salt. So these can be an options for the patients. Use of lemon juice or fresh ground pepper to ascend the natural flavors. Then avoid herbs or spices mixture that contain salt and sodium. We all are fascinated to sauces, ketchups, pickles, papads. They are very high source of sodium. Foods rich in saturated fats are also high in your salt. Like all your burgers, your hamburgers, your chicken burgers, they have too much of salt. So they have a top up of cheese and all. Again, cheese as salt. You need to understand when the food is having high saturated fatty acid content, it goes hand in with salt. So these again are very low in the cardiac friendly fatty acids. So we should try to avoid them, which are having the junk or fast foods. Red meat, lard, and hard stick margarine should be avoided. Pickles, papads, chips, savory items, your khara, chulwa, bhajia, samosa, all those. Cheese, butter, biscuits, bread, sauces, ketchup. You may be saying that we can consume white butter, which is devoid of salt, but it is again high in saturated fats. But patients who are really sick, having some malabsorption component, yes, white butter can be given because that is rich in medium chain triglycerides that gets better absorbed in the gut. So to avoid trans fats, American Heart Association and Diabetic Association recommends zero fatty acid trans fats for the cardiac patients. So to avoid sweets and sugar sweetened beverages, you have this high fructose corn syrup preparations. So these are very, very dreadful for the heart patients. So packed fruit juices, aerated beverages, flavored fruit juices, squashes, thick shakes, sodas, these do have sodium benzoate as preservative. So we need to avoid all these. Rich coffees like your mocha, latte, cappuccino, they also have sodium and other preservatives. So we need to avoid them. Remember, caffeine should be limited due to possible increase in heart rate and dysrhythmias. No more than 1 or 2 cups of coffee per day. Record daily fluid intake, which is really, really important. As Sir was mentioning about the urine output, I always insist on input. You all need to understand what is 200 ml, what is 100 ml, what is 50 ml. You should know which cup size you are giving, if it is a big tumbler or a glass. So that amount of volume, you should make a note of it. If the glass is 200 ml, the FNB person serves 175 ml and the patient takes 100 ml of it, but you mentioned 200 in that. So please don't do this. You need to understand, it's a minimum common sense that what is going into the patient's body is most important as what is coming out of the patient's body. So check the body weight at the same time each morning, especially before your breakfast, before the patient's breakfast, and after urinating. Sudden weight gain or loss can be a sign of developing HF. Be physically active, and we need to have an exercise regimen, which is really important. And the physical activities should be scheduled as a part of our lifestyle. If moderate exercise is not possible, structure rehabilitation program can be opted. So we should learn to manage stress. Meditation for 15 minutes twice a day is mandatory. Deep breathing exercises like pranayama or practicing minimal yoga. We don't need to do a strenuous activity of yoga of different chakrasans, but the basic yogas which will be tuning the body circulatory system, keeping the pressures under control, and keeping the mind calm should be adopted. Adequate rest, at least 6 to 8 hours of sound sleep is mandatory. Use pillows to prop up your head. Avoid naps and big meals right before bedtime. So, trying napping after the lunch is important. Put your feet up for few minutes every couple of hours so that we don't have pedal edema. So, avoid alcohol, which is really, really important. It increases the blood pressures, weakens the heart muscles, elevates the triglycerides, leads to thiamine deficiency. So, we need to understand that there's a big no for alcohol. And quit smoking. So, it damages the blood vessels, thickens the blood, high blood pressures, it leads to coronary heart disease, arrhythmias, heart attacks, stroke, and PVDs. And one out of every heart failure is going to die with smoking only. So it is so dreadful that person who is a smoker is having a high chance of death. 70% of the smokers tend to die quickly with heart failure when compared to the other population. This is a study done by WHO and World Federation of Heart. So any questions I would like to answer. Thank you for your patient listening. It was a quick presentation. No questions? Thank you.
Any questions? The people on live can post your questions in the post box. So thank you, ma'am, for that wonderful speech. So the next speaker is going to be Dr. Sridhar. Okay, our Dr. Sridhar sir is our consultant physiotherapist working with us, having more than 15 years of experience. He is expert and in handling the cases like shoulder rehabilitation, manual therapy, tapping techniques, and post-surgical rehabilitation cases. Okay, he is one of the best outgoing student from his undergraduation program from the college, and he got graduated in Masters in Physiotherapy in the Department of Orthopedics from Dr. NTR University, and is having a very good experience, almost it's 15 years experience, and a very long clinical career with us. Okay, over to you, sir.
Hi, good afternoon all. All. Um, Myself, I'm Dr. Sridhar, physiotherapist, and I will tell you briefly about the cardiac rehabilitation. Generally, in hospitalization only, we'll do from the day one onwards, we'll do the cardiac rehabilitation therapy. In this one, main objectives are the introduction of cardiac rehabilitation, and in this one, we'll explain about the definitions, goal of cardiac rehabilitations, and benefits of this program, and main indications and contraindications for the rehabilitation program. And in this one, we have mainly of 1 to 4 phases of exercise therapy programs is there. We'll see about that one by one. This is the main cardiac rehabilitation program definition. The coordinated multifaceted interventional design to optimize a cardiac patient's physical, psychological, and social functioning so that they may their own effects and resume the maintain as a normal pace of possible in the community. Mainly thing is to bring back to the normal life of the patient. The main goals is to just reduce the pathophysiological and psychological effects of the heart disease and limits the risk of reinfraction and sudden death and reduce the cardiac symptoms for the patients and like that reintegrate the heart diseases and patients into the successful function of in the status of their families and in the society. So what are the benefits we'll get this cardiac rehab program? Main thing is to enable the patients to return to the activities of daily living and reduce the cardiovascular and total mortalities and improves the myocardial perfusions. These are the benefits we'll get this by this rehab program. For this one, we have to do the indications for this one. Cardiac rehab program is to acute all the patients who are having acute myocardial infarctions, coronary artery bypass grafting, angioplasty with or without stenting, valve replacements, and repairs, heart transplants, and etc. And the congestive heart failure also, this one were included in this one. The contraindications for the cardiac rehab is unstable angina, uncontrolled erythemia, recent embolisms, and poorly controlled hypotension. Patients, main thing is patients who are unwilling to exercise also, this is contraindicated in this one. It's a core components are mainly thing is patient assessment, nutritional counseling, weight management, blood pressure management, and lipid management, and tobacco, stop tobacco consumptions, exercise training, and physical activity counseling. Main thing is to reduce the risk factors. Is, in this one is the first one is the blood lipids. We have to reduce the total cholesterol, LDL cholesterol and triglycerides. We have to increase the HDL cholesterol levels with this training exercise program. Next one is the hypertension controls and the glucose intolerance. With exercise programs, the increase in insulin sensitivity at the cellular levels will definitely compromise this glucose intolerance, decrease the serum triglycerides and body fat levels also. The main in cardiac rehabilitation program, we have 4 phases, and first phase is mainly to 5 to 7 days from the day one. In this one, we have to mainly is medical evaluation for the patient, education of the patient, and risk factors. What are the risk factors assessment, and mobilization of the patient and discharge planning. The first phase is day 1 to 7 days. In the first phase, we have these are the goals we have to set up for the patient. Assessment of hemodynamic response to the self-care and progressive ambulation activities. Determination of effectiveness of the patient medications in controlling abnormal responses to the activity. Establishment of the clinical data that contributes to the patient prognosis and thus optimize the medical management. These are the protocols. Main thing comes here. In this one, step 1 is to passive range of motions. We'll in the hospital program, we'll start with the passive range of motion exercises. Then slowly we'll progress to the another one. In this one, passive range, active ankle, along with passive exercise, we'll do ankle exercises, and patient able to do self-feeding and orientation to the program. Step 2 is to same exercise with the legs in the bedside sittings, legs movements, and next one is the active assisted ROM exercise, sitting on the chair, bedside commode, and more detail about the explanation of the program is more important. And patients has to adapt to the ideal activities and walking. Step 4 is the minimal exercise, increase the sitting time, and patient education is the most thing. Light activities and independent ideal act in walking. Next one is the moderate with we have to continue with the same exercise with the moderate resistance and sitting for the meals, teacher ADL activities, and continue patient education. Next one is increase the exercise program, review the energy conservation and the pacing techniques, increase the exercises with the light weight and increase the walking distance, increase the craft activities like in the room itself, and discuss the home exercise program. Next, we enters into the second phase. Mainly to second phase yet the- after discharge only second phase starts. It's around up 8th day to 6th weeks it will be there. And the main thing is addresses the health education, exercise, and stress management. In this also main goals is to increase the exercise capability and endurance, safe and progressive manner. Teach the patients to apply the techniques of self-monitoring and home activities. Increase the patient's main knowledge about the home activities, what he has to do or she has to do. And the exercise is the frequency where in the hospital itself we are done with slowly, and the frequency has to increase 3 to 5 times a week, and the intensity is main thing. Testing heart rate has to be plus 20 beats per minute, and METs 2 is almost equal to 4. The time is the 5 to 10, 30 minutes of time duration for the exercise program. And in this one, we have to encourage for the sitting, standing functional activities, ROM exercise, and walking. And next one is the phase 3. Phase 3 is from 6 weeks to 12 weeks with limited ETTs, and the results of this one are used to determine the target heart rate for the exercise program only. Our goal is to main thing, it has to come to the normal activities, improve and maintain physical fitness, provide professional supervision for exercise, continue with educational and behavioral programs. In this one, after walking, we slowly increase to oh, increase the workload on the heart, maintain the constant maximal intensity, and like this with a jogging, increase of walking, stepping stairs, and cycling. In this one, exercise is followed by the rest of intervals also, and high intensity work can be achieved as there is a appropriate spacing of work and relieve the intervals. After that, warm up period also be there to increase these muscle temperatures and increase the need of oxygen, and the dilatation of previously constricted capillaries, and with the increase of circulation decrease the susceptibility of the musculoskeletal systems to the injury by increasing flexibility. In this stage, the frequency is gradually increased. 60 to 70% of the maximal heart rate will get, and time is to 20 to 60 minutes. In this one, exercise are little bit increased, and aerobic exercise and endurance training will be given in this phase. After every phase, it's a cool down period will be there. This one prevent the pooling of the blood in the extremities by counting the muscles to maintain the venous return. Enhance the recovery period with oxidation and metabolic wastage and the replacement of the energy stores. Next one is the fourth phase. Fourth phase comes means a patient is almost is getting cured. Main goals is the to improvement of the maintenance of fitness program only, and self exercise has to be increased. Long term behavioral modifications has to be adopted. In this program, frequency is the main 1 sessions per day. Intensity has to increase 60 to 80%, and time period has been increased from 30 to 60 minutes. And in this one, dancing, hill climbing, and resistance exercise will be added. Main thing is cardiac rehab. What we up to know these 4 phases goals and benefits of this program. And finally, we have to give the assessment outcome. Thank you.
Thank you, sir. Any doubts? Yes, sir.
Basically, much importance given to diet, role of dietitian and physiotherapist or exercise training in this session. Why? Because so when 2 months back when we launched advanced heart failure clinic, just as a to call some patients. So we identified patients with the EF around less than 25%, and then we called them saying that just come to the clinic. So then one patient came, he's a farmer, but he's working in, he's doing routine agricultural activities and he walks almost 5 kilometers per day. He's a poor fellow, 25% EF. So usually, so with this is a role of exercise training and then diet, it plays a big role. So he is on minimal medication. So if you uh, educate about, if you see that the kind of patients, usually many people, so non-medical or any people, they say don't do much activities, just sit and uh, no. So it plays very big role in heart failure management. Okay, that to uh, show the importance of this dietitian and then rehabilitation. That is a we have to focus on about this cardiac rehabilitation. Ideally, this has to be started in hospital. So we started cardiac rehab in our OPD department, where one dietitian and physiotherapist will see only heart failure patients. One thing is it has to start in hospital once the patient is admitted. So we have to inform the coordinator, and as well as you have to give a call to cardiac rehab. So that means the same persons, whoever is following them in OP, so they will start doing this cardiac rehab, both diet and exercise training in ICCU itself. So because they will structure it, even diet, it has to be individualized to the patient, not a blanket diet sheet. So because it depends upon the sodium and fluid and everything, and they have to titrate as the patient improves. Even exercise also same. So in ICCUs, first they do some chest physiotherapy and basic things, and then with that the patient will be little confident enough. So he will psychologically he will become strong. So once patient is independent, he can do some activities. Then that it gives some motivation, and then they will go for the next phase. Then before discharge, they'll make them to walk and they'll get some confidence. And same patient will be followed by same dietitian and same physiotherapist in OPD basis, so that they will have a good quality of life. So that is the reason why. So all patients who are admitted with heart failure, just to give a call to coordinator. So then she will collect the data and she sees that the treatment, pharmacological treatment suggested by guidelines, AHA guidelines, whether it's being followed or not. So that all the patients with heart failure admitted under all the consultants, so at least they will be monitored. It's a passively monitored. She will collect the data, and then whether they are taking ACE inhibitors or they are not. All the medicines, okay, they are prescribed or not. And then at the time of discharge, she will also counsel, and then you have to counsel the patient as well as the patient's family members regarding the medication, and then what to be followed, and then we have to give the educational material to them. Okay, right? So these things you should follow. Right, ma'am? No. Just she will fill the initial assessment form, so that this is like a baseline. What are the risk factors? Okay, just we'll maintain the data. No, no, no. She won't do. This is not actively. So just she'll go and she'll collect data like what are the risk factors at the time of admission, what was the EF, and then suppose heart failure. So any reversible causes are ruled out or not, the tick marks. So just like if any angiogram was done, fine, some any angioplasty and those details. And at the time of discharge, the whether patients are taking the medication started on medications or not, if not any contraindication. So that in the next follow-up, so then with this dose, whether they're tolerating or not, and then we have to up titrate to achieve a maximum benefit. Actually, we have to go to the maximum dosages of all the medicines. If you start Ramipril 2.5 mg, to achieve a benefit, you should go up to 10 mg. Beta blockers, we usually will start with 25 mg, metoprolol. Maybe you have to go to 100 mg also. Okay. So Vimada, we start with 50 mg twice a day, but maximum dose, best dose studied is 200 mg BD. So then each OPD consultation, we have to try to increase the dosages. Otherwise, there is no benefit. So actually, those doses are not sufficient. They are not the studied dosages to get a maximum benefit. Okay. So and then if you even physiotherapy and the dietitian role also, they have to start from the ICCU and it has to be individualized in hospital. Then only they'll come back to the same person and they will follow this thing. So but to coordinate this thing, so there should be some coordinator that she is there. Soumya, she's a D pharmacy. She joined 1 month back. So then she will coordinate these things. Okay. Right. D pharmacy. Anything?
Any doubts, any questions, please post in the post box. Okay. Now we have come to the conclusion of our program. I take this opportunity to thank Dr. Nitin, who was behind this program and who would make sure that all this program has come to one success. I want to thank all the participants who are here and want to thank all the resource persons who spoke today. And I want to thank our nursing management team, Swati Madam and GB Ma'am, for helping out to make this program to come out a successful one. And we have given you a feedback form. So I want all of you to submit the feedback form to Mr. Hemant. And within short duration of time, you will get a link regarding the post session course, this assessment post test you will be having. So you'll be getting a minimum of 15 questions. So I want all of you to answer these questions. So the link is sent. So due to lack of certain things, we could not able to give it in a physical form, paper form. So you'll get a link, Google Sheet. So I want all of you to answer these questions and submit the answers by end of the day. So right now we have another program. We have a program, auditorium is occupied, so we'll disperse for our lunch. See, yeah. We'll have one group pick. I want everybody. Sir. Hemant.